Thank you very much. Thank you. Thank you. Our guest of honor, our Principal Secretary for the State Department of Medical Services, Ari Kimtai, His Excellency the Governor of the great county of Elgeyo Marakwet, Honorable Wesley Rotich, the Chair of the National Assembly Committee on Health, Mheshimiwa Patrick Munene, who is also the Member of Parliament for Chuka Igambangombe, and also your fellow committee members. Honorable Ron is there, Honorable Senior Dr. Nyikal, Honorable Kibagendi, Honorable Madenge, and also Senator Catherine Muma. We appreciate and we recognize your presence here. The NSDCC board, the board of the National Epidemic Disease Control Council, led by our chairman, Geoffrey Gitu, and the CEO, Dr. Ruth Laibon Maisha, the Director General of National Council for Population and Development, Dr. Sheikh Mohammed, our development partners who are here. I see the UN families here. Harriet, I can see you. I can see my brother Brian Redman from PEPFAR. Communities that are here, our friends, colleagues, ladies and gentlemen, good afternoon. Good afternoon once more. Honorable PS, we have been here, and delegates have come here from all the 47 counties, including the county executive committee members and the county directors of health. I'll be requesting them at some point to just stand up and be acknowledged. And for purposes of time, or because time is also against us, I would have wished that you know each and every of these individuals who is here today, each and every delegate who has come from far and wide to come and mark this journey with us. However, I will do so, I will request with your permission that I do so in terms of groups, so that as I introduce the group, as I name the group, you can stand up and we acknowledge you, and please, we applause and welcome them. We have delegates who have come from outside our country who are very important. I can see Dr. Raymond Yekeye from the Zambia National AIDS Council. Makofi, Professor. Thank you very much. Thank you very much, Prof. And I know some of our speakers have also come from over the seas and over the lands. When you are given a chance to speak, we'll also duly recognize you. The members of parliament, honestly, it is you, PS, will recognize them, and the chair is here. Fellow colleagues from the national government ministries. We have Ministry of Health, we have Ministry of Education, we have Ministry of Gender, we have the National Treasury, we have Ministry of Interior, we have Attorney General's Office, we have several ministries, departments, and agencies that are represented here. Kindly let us all be upstanding, apart from our CEOs, let us all be upstanding so that we can be acknowledged. Everybody from the national government. All of us, please be upstanding. Makofi, si unaona wamekuja vizuri? Thank you very much. Thank you very much, colleagues. Behind you is the board of NSDCC. The chair will introduce the board when the time comes. The board, the representation from NACADA is also here, and we were with them yesterday. Our brothers and our colleagues, our government colleagues from the county governments, led by the county executive committee members and the county directors of health. Kindly, I request with humbleness and humility that you be upstanding so that we can acknowledge you. I know your leadership here. I saw Dr. Timothy Ombati. I saw Dr. Ruth Koech. Please be upstanding. And the directors as well. Piga makofi mawaziri. Asante sana. Asante sana. Here is Director Okomo. Director Okomo is the chair of the directors. Dr. Timothy Ombati, where are you? Yeah, he's the Secretary General of the caucus of the CC members. So we have representation of the technical arms in the county government that are running this response and working with us. Mheshimiwa mgeni wetu mkuu, pia we have two deputy governors who have joined us this morning. We have His Excellency Dr. James Lowassa, who is the deputy governor for Isiolo County. Makofi ya Daktari. Thank you very much. And we also have Her Excellency Christine Kilalo from Taita Taveta County. Makofi tafadhali. Thank you very much. Dr. Lowassa is also the CC member for Isiolo County, as well as the deputy governor. Then, very importantly, we have the communities. We have communities of persons living with HIV who are our heroes and our heroes, and to celebrate them. And the reasons we're here. Please, can you all be upstanding? Communities, please be upstanding. Otuma team, please be upstanding, all of you. I saw Mzee Davis here, Kamau. They have come in their numbers. Makofi tafadhali. Thank you very much. Thank you, Kamau. Thank you, seniors. Thank you. We appreciate you. Thank you. We also have, they call themselves Watunguyas, the young people. Mupo? Vijana mpo? Hebu simama pia zaone tafadhali. Simameni, simameni, simameni. Ai, hata msimami na heshima. Sawa, makofi ya vijana. Thank you very much, thank you. Also, we have other communities of key and vulnerable populations. We have people who inject the drugs. My brother there had already spoken. Yeah, he's your brother of the photo. Is there. Stand up, Ahmed. Thank you very much. We have key populations of female sex workers. We have key populations. We have key populations of men who have sex with men. So all of us are gathered here in one accord of ending AIDS as a public health threat. Asanteni sana, and thank you for coming in your numbers. Chief guest, they are our development partners, both bi and multilateral, and I'd wish that the UN agencies that are here, PEPFAR, and all the development partners who are here, kindly be upstanding also so that we can acknowledge you. Makofi, makofi, makofi kwa wafadhili. Maureen Murenga, wherever you are seated, you'll agree with me that we could not be having this community of people living with HIV were it not for these development partners today. So we sincerely appreciate you. Thank you very much. Also, we have other partners, other implementing partners. We have Kenya Red Cross with us. We have the AIDS Health Foundation. We have Georgetown University. We have CAVI. We have PS Kenya. We have LVCT. We have the Elizabeth Glacier Pediatric Foundation, EGPAF, who are going to be making a presentation after this. And also, we have residents and citizens of this very beautiful county, coastal beach county of Mombasa. They are here with us, as well as the staff from all these institutions that we represent. Kindly, with humility, if I have not mentioned your group, and the religious leaders, masheikh wako hapa, tafadhali na mapadre, msimame, shake, please, tafadhali, appreciate our religious leaders. Thank you very much. Sheikh prayed for us in the morning and dedicated this meeting, and that's why this meeting is going on well the way it's going. If you look at the program, we are done fairly well. We had covered the section of the morning where we were having presentations from the communities. We have had the voices from the communities. Otuma has spoken here. Patricia has spoken. Ahmed has spoken, and as well as Guantai, they have spoken. The next set of speakers, they are going to be very brief because of time. The first speaker that I'm going to invite, Honorable Principal Secretary, to speak to us is Dr. Eliud Mwangi, who is the Country Director of Elizabeth Glacier Pediatric AIDS Foundation, EGPAF. These are our partners who have done a lot in this country. Makofi ya daktari anapokuja tafadhali. Thank you, daktari. Welcome.
Thank you so much. Good afternoon. The PS for State Department of Medical Services, Harry Kimtai, allow me to stand on the protocol already established because of time, and also because I want to speak on a very special group of the population. And this is a population that has been left behind in this fight, and these are children. We have done well. I must say that we have made great progress as a country. We have seen that we have really made a lot of progress, even for the general population. We are at 95, 95, 90. If at all you look at the 95, 95, UNAIDS targets. But for children, we are still at 85, 85, 74. So if at all you are writing anything, just say that we are leaving our children behind. Traditionally, or with the African culture, we used always to ensure that when we cook, who used to eat first? I want you to hear, I want you to speak to me. When we cooked our food, who would eat first? Again, our children. But in this fight, we are leaving our children behind. And you can clearly see in this room, we don't have any child. And that's why, as Elizabeth Glaser Pediatric AIDS Foundation, for the last 35 years, we have been fighting to end AIDS in children in this country for the last 25 years. And I must say that there has been a lot of progress, and we really need now to focus, really to see how we can eliminate pediatric AIDS. We can never achieve an AIDS-free generation without eliminating pediatric HIV. So it all starts with children. Do we agree? We shall start with children. In this country, we are still having about 9% of mother-to-child transmission. That means that in every 100 women who are HIV infected, about 9 of them are transmitting HIV to the unborn child, which is unacceptable because we have the science, we know what we need to do, and I really want to ask all of us to join hands to ensure that we eliminate mother-to-child transmission, we end pediatric AIDS, and then we shall be able to end AIDS in this country and even globally. I think finally, the question is, what do we need to do? And I have just a call to action on only 3 things. One is on advocacy. We must be the advocate for children. We must be the voices for the children. They are not in our boardrooms. They are not in meetings. They are not in parliament. We have the members of parliament. I can see my friend Joshua. We worked very closely in Kisumu many years ago. They are not in parliament, but we really need to be the voices for children. And I'm actually requesting the members of parliament, if you can have a parliamentary pediatric caucus, a team that will just be thinking about children issues, I think you'll do a good and a great service for these children and for this country. So that's one of the requests I want to make this morning or this afternoon. Can we have a pediatric or parliamentary children caucus in parliament to ensure that we are really able to voice issues of children at the highest level in this country? Number 2 is the funding. We really need to ring-fence funding for children. As we talk about funding for HIV/AIDS, we forget that in there, we must have funding for children. Because as we have said, children used to eat first. Therefore, when you put food together and you expect that the children will somehow compete with the adults, then children suffer. So I'm requesting all of us, can we ring-fence funding for children? So that if it is domestic financing, when you say that you have a health budget, can we also ask how much has been allocated for our children? We are leaving children behind in HIV. In TB, we are only diagnosing only 44% of children who have TB. And you know that TB is the biggest killer for our children. Then finally, is about the communities. We can only succeed if we work with communities. I'm very, very happy with the primary healthcare initiative that the government is doing. The 100,000 HCPs, or healthcare promoters, are going to make a big difference in this war. So let us support the government. Let us work together to achieve this goal. And as the Elizabeth Glaser Pediatric AIDS Foundation, we are committed. We have been here for the last 25 years, and we shall be here until we eliminate pediatric HIV. God bless you.
Thank you very much, Dr. Mwangi, and thank you for the partnership, and thank you for the commitment that you'll continue being here. My next speaker comes all the way from Georgetown in the United States of America. He's a long-standing public health practitioner, more than 28 years of experience and practice with an interest in academia, public policy, and healthcare service delivery. He's an associate professor of medicine at the Georgetown University Medical Center in Washington, D.C., United States of America, and is one of our sons who are in diaspora, whom I talked about, who have come back to share with us their experience. Ladies and gentlemen, please put your hands together for Dr. Deus Bazira. Makofi. Asante.
The Principal Secretary, State Department for Medical Services, all distinguished guest protocols observed, children, the youth, ladies and gentlemen. It's an honor for me to be here speaking to you at this conference. I bring you greetings from Georgetown University in Washington, but also from my colleagues here in the audience. And I'll briefly speak about a topic of interest and closest to my heart and those of my colleagues, and that is the question of resilience and building resilience into our health systems. For those of us who are not young, sorry, the young people, I'm not trying to discount your experience. The 1980s, 1990s, and the early 2000s were dark years for some of us. We witnessed families torn apart, senseless death, senseless in that this was preventable, lost hope, lost productivity, and in some cases, our faith was tested. And the AIDS epidemic or pandemic then stretched health systems to the limit and almost crushed the health systems. However, due to the resilience of humankind, and through powerful coalition of individuals, families, communities, civil society, faith groups, governments, global institutions, committed local and global leadership, and through the power of effective partnerships, bringing science, practice, activism, advocacy, and financing, the largest ever response, public health response, was mounted against this killer epidemic. It is through such initiatives that the UN made declarations, made commitments. We all know of the Global Fund. We know the US President's Emergency Plan for AIDS Relief, and our national governments that made lots of resource investments to turn around the tide against AIDS. Fast forward, 3 years ago, we again faced another testing moment. And this was another cosmopolitan event, as we say in health security science. And that was the COVID-19 pandemic. And then we quickly realized that the investments made in the HIV response had created powerful and effective platforms and health systems across board in data systems, the health workforce, the policy environment, and this was leveraged to respond to the COVID-19 pandemic. However, in all these situations, this was not necessarily intentional. In some cases, it was ad hoc. So if we are going then to deal with the next threat, and mark my words, it's not going to take another 100 years till we get tested with another pandemic or another global event of public health significance, we will need resilient health systems with inbuilt capabilities to address the needs of our populations on a daily basis, but also at the same time have inbuilt capabilities to pivot and address any threat that we face. And I use the word capability because it's different from capacities. We tend to focus a lot on capacities. Capacities is what you have or what you are. Capability is really more about what you can have or be, if I may quote Saint Amateur, one of those I respect in the field of public health. So for us to then build resilient health systems, what do we have to do? We've got to look at the shocks that face our health systems and the chronic stresses. And these come in all different forms. Some are acute shocks, like huge traffic accidents, long shocks like pandemics, short repeated shocks like seasonal weather events, I come from Uganda where we get lots of landslides almost every year. We know it's going to happen, it's predictable, but how prepared are we to respond to it? And then, of course, we've got these chronic stressors and contextual challenges compounded by a lack of resources or limited resources. However, what I know, we are here to talk about HIV response and how to end AIDS, and we should stay focused on that. I think COVID-19 has shown us that we are going to be faced with so many challenges at the same time. Therefore, we have to chew gum and walk at the same time. We have to be able to respond to HIV, respond to an emerging pandemic of diabetes and cancers, deal with the demographic dividend that we've been given, especially for African countries. But that population also presents its own challenges if we are not prepared to deal with their population health needs in the future. So I implore you that we've got the tools at our disposal, both through emerging and new technologies, the commitments, the resources, the expertise, the experience, to start looking at things through a lens of integrated delivery and response, and also start breaking down barriers for vertical interventions in order for us to achieve sustainable population health impact. I invite you tomorrow morning to one of our sessions that will be discussing these issues in detail. Once again, thanks for the invitation. Enjoy the conference.
Thank you, Diaz. And indeed, we know that the virus does not know borders, whether it's Uganda, whether it's Kenya. That's why one of the anchor principles of this conference is partnerships, that we have to partner. We have to partner internally, partner regionally, and partner internationally. On that point of partnership, Honorable PS, allow me to invite a special delegate. As you know, PS, the Presidential Emergency Plan for AIDS relief is the single largest bilateral program in the world supporting the HIV response. And the country coordinator here is Brian Reitman. Brian holds a Master of Public Health from Emory University, but he's also an African. He's more of an African, actually, than the speaker who has just left the podium. He's worked in Botswana, he's worked in Uganda, he's worked in Tanzania, and also he's worked in Guyana, and now he's working in Kenya as the country coordinator of PEPFAR. If I took time to read all the bio parts of Brian, I could take the next half an hour or 1 hour. But kindly at that, Brian, allow me to invite you to the podium to speak with us and share your experiences. Our hands together, please, for Brian. Thank you very much. Thank you. Hiyo makofi haijatosha ile pesa tunapata. Tafadhali, makofi kidogo. Thank you.
Look at that shining face. All right, Asante. Thank you. Thank you, everyone. PS Kim Tai, Governors Rotich and Nasir, members of Parliament, our hosts, NSDCC, and particularly Dr. Maisha, county government representatives, implementing partners, and community members, all protocols observed. It's a challenge following Deus, because I think he stole my speech. So thank you. It's good to see you again, by the way. So I'm excited to be here to celebrate the opening of the Maisha conference, to acknowledge the incredible successes Kenya has achieved toward ending HIV as a public health threat. PEPFAR is proud to be a long-standing partner of the Kenyan government in these efforts, and we look forward to continuing our important work together. With more than 1.3 million Kenyans on treatment, and 94% of them having successfully suppressed the virus, we can say we're on the cusp of epidemic control. However, we must not rest. Each year, there's still 18,000 deaths due to HIV, which is down from about 130,000 in 2003. And there's also 22,000 new infections, which is down from 110,000 infections in 2003. So we've got more way to go. But before discussing the way forward, I'd like to first stop and celebrate PEPFAR in its 20th year and thank our Kenyan partners for all their hard work over the past 2 decades. I'd really also like to thank our implementing partners. There are several in the room that you've heard from, because they're really accomplishing the success that we talk about. PEPFAR, as mentioned, is the largest commitment by any nation to address a single disease in history, and it's been enabled by bipartisan support across 10 U.S. Congresses and 4 presidential administrations. For the last 20 years, the U.S. has invested over $100 billion to fight HIV, and U.S. leadership through PEPFAR has transformed the global HIV/AIDS response. PEPFAR has helped more than 25 million lives and has prevented millions of HIV infections and supports more than 20 million people on treatment in over 50 countries, all without a vaccine or a cure. In Kenya, PEPFAR support has saved a significant number of lives throughout the country, and together with the government and the people of Kenya, we are changing the trajectory of the HIV pandemic, and PEPFAR has supported many achievements, including more than 110 million tests performed since 2004, VMMC for over 2.5 million men since 2010. We currently care for about a little over 600,000 orphans and vulnerable children, and of course, as mentioned before, 1.3 million people on treatment. About 1.3 million. PEPFAR will continue to work with NSDCC, NASCOP, and Council of Governors, as well as civil society and other development partners, including the Global Fund, to evolve the package of services for HIV to provide Kenya with the opportunity for a more sustainable HIV response. The new Bureau for Global Health Security and Diplomacy, which you all probably know as OGAC, or the Office of Global AIDS Coordinator, is asking each country to develop a roadmap that defines how we will sustain the gains we've achieved. The government of Kenya's push to implement universal health coverage through enhanced primary health care really gives us a great opportunity to better integrate HIV services and break down those barriers that were just discussed, and break down the silos. So we need to develop new models that bring services and drugs closer to the patient. For the sustainability roadmap, we should include those models of service delivery and draw up strategic plans with defined timelines on how this will be implemented county by county, recognizing that the epidemic is different throughout the country. We also need to take greater advantage of the opportunities that Kenya has to engage with the private sector. This includes providing greater opportunities for private sector providers to engage with HIV patients who are willing to pay for enhanced services. It's continuing to engage the private sector through social contracting, and it's also increasing engagement with local manufacturers in Kenya who are capable of producing ARVs, rapid diagnostic tests, and other supplies. We'll also look through the roadmap to identify needed capacity building or capability building as well of counties and facilities to ensure that they are ready for those transitions that we planned. So together, working with our partners in Kenya, we look forward to ensuring our gains will be sustained for the next 20 years and beyond. Asante sana, and I look forward to a successful conference.
Thank you. Nilisema makofi ya pesa, makofi kabisa vizuri. And for friendship and partnership of the American people. Brian, they have said you are a very good man. Eh? That's what they have said. Thank you very much. Now, the next speaker, again, colleagues and honorable guests, is a brother from the Eastern Africa part of this continent, Eastern and South. You can call it Eastern and South. Zambia is both Eastern and South, I think. It's just in between. And when you look at the global statistics, we are the people who are not doing very well, especially among the adolescents and young persons, in terms of our indicators in ending HIV among adolescents and young people. Dr. Raymond is a public health specialist. He's the director of programs at the National AIDS Council of Zimbabwe, which is the equivalent of the National AIDS Control Council in Kenya. Over 25 years of experience in HIV sector and health programming. Wide array of experience working with the non-government organizations, the United Nations, and government, and also currently is the Global Prevention Coalition co-chair. So he comes with a heavy CV from Lusaka. He arrived yesterday. He's going to be with us until Friday. Makofi tele kwa Dr. Raymond. Welcome, Dr. Raymond.
Thank you very much, Chair. And a disclaimer right at the beginning. I am from Zimbabwe, but not very, so we are neighbors. At some point, Zimbabwe, Zambia, Malawi used to be the federation. So no offense, Chair, Master of Ceremony. But let me ride on the protocol that has already been observed, but also just recognizing the PS, the governor, my colleague and friend, the CEO for NSDCC. I am honored and pleased to be part of the Maisha conference. I think special thanks to my colleague, Dr. Ruth, for following up on a promise. I think this invitation was done informally initially during tea break when we were debating on whether we should support certain decisions that were being made about the HIV response in Geneva. And we said, okay, we can, I will definitely make time. And so thank you very much for following up on that. I think my participation provides an opportunity for South-to-South learning. And I think we already have some of these platforms provided for. But this is a first of its kind where we are invited to the national conference to actually share our experiences. I am not going to be speaking at length now, as I have an opportunity to speak in another session where we are focusing on sustainability of the response. Let me highlight the fact that Zimbabwe and Kenya share an excellent history in terms of sharing experiences. And this is not the first time that I've been to Kenya to learn, but we have also hosted colleagues from Kenya in Zimbabwe looking at the possibility of setting up an AIDS trust fund for Kenya, as well as ourselves coming here to look at your progress in key populations programming. Our responses are similar in nature, and our challenges towards ending AIDS by 2030 have a lot of similarities. Zimbabwe, just like Kenya, has significantly reduced its new infections, and we have actually achieved our 95 targets. We are one of the top 10 countries in the reduction of new HIV infections, and I think this is highlighted in the UNAIDS Global Report. Our population for HIV is 1.3 million, which looks, if I'm talking about these numbers, it's like I'm talking about Kenya. Our prevalence is 11%, and our incidence is 0.17. And we currently have an estimated 17,000 new infections occurring annually. Despite all these seemingly very beautiful numbers, we do have challenges that we are having new infections across certain geographic areas, and I heard there's going to be recognition of certain areas that have done well. We have areas that are not doing well, particularly amongst adolescent girls and young women, as well as our key populations. I think one speaker has already talked of one area that we also remain facing challenges, which is the MTCT rate. And our mother-to-child transmission rate is still very high at 8.1%. We are still experiencing high deaths, unacceptably high, let me put it that way, as we are experiencing around 20,000 deaths on an annual basis. We are noting that we still face rising HIV-related stigma and discrimination, especially amongst our key populations. And we are noting again, and Kenya has moved in a great way in this, we are noting new evidence of non-communicable diseases amongst our people who are living with HIV. I'm taking this opportunity, PS, and also Dr. Ruth, to inform you that we are organizing the CASA conference in December 2023. This is 4 to 9 December. And we are looking forward to, as usual, a huge contingent from Kenya. Our statistics for ICASA, I think when we looked at the 2015 ICASA, I think Kenya had one of the biggest delegations. And we are looking forward to your support in attending the conference. One of the things that makes it easy for us to invite Kenya to attend ICASA is that there's no visa requirement for coming to Zimbabwe. I think that's the first one. So if you want to either drive or fly, you can do that. We also know that there are about 4 flights just from Nairobi to Harare on a daily basis. And so this should make it easy for all of you who are here to attend the conference. Registration is open. We have already had early registration happening and closing. The charge for attending ICASA 2023 is 500 United States dollars. Once again, let me take this opportunity to thank you for inviting NAC Zimbabwe, and we look forward to hosting you and the other Kenyan delegates in Harare in December 2023. Thank you very much. Asante sana.
Thank you very much, Dr. Yekeye. Honestly, it was a slip of the tongue. We know each other very well, we are friends, and I don't know how Zambia came to my... So, they have apologized for me. Do you apologize for me? Thank you very much. Asante sana. So, I want to just do it a 1-minute breaker and invite Pato. Pato, can you give us some sort of energizer? So people have been here since morning. Eh? Just 1 minute. Okay, we proceed then. We proceed. I can see Honorable Roni has requested me that we proceed so that we can save on time. Thank you. So at this juncture, let me hand over this program to the CEO of National Epidemics Disease Control Council, Dr. Ruth Maisha, to make a presentation together with our colleague, Dr. Sheikh, and also run with the rest of the program. Daktari, karibu sana. Dr. Ruth Maisha is the CEO of National Epidemics Disease Control Council. Makofi yake, please, tafadhali. Thank you. Si hata na mimi mnipigie kidogo tu hata kama... Thank you. Asante.
Thank you very much. The governor has denied me the opportunity to dance. So I shall revenge. Good afternoon. Let me take this opportunity to, first of all, sincerely thank everyone. Our Principal Secretary, allow me to recognize protocol through you. And also apologize that we did not start this particular event in good time. But I want to assure all the partners who are here today, we were actually working. And it became so interesting because you set up so many booths outside there that the PS took so long to listen to every presenter outside there. And I kept telling him there are so many others in the room. So, but thanks to the people who did the display, I think you've learned a lot. Yesterday, we spent the day with the members of parliament. I really want to sincerely thank the health committee for spending the day with us to understand our work. Tunaweza wapigia makofi. And by the end of the day, we said this is a parliament with a difference. Because we started our journey at 8:30, and we were still together until almost 6 p.m. discussing what we had seen in the field. We were able to visit now what Parliament has directed us to use the name no longer as dens, but drug users basis or sites. Yes, we have to get the new name. But of key importance is for us to have seen what people are doing out there trying to work on the drug users program. We were able to follow that program to the Miritini site, and we were able to see those who are outpatient and inpatient. Really an eye-opening event. So allow me at this juncture, my role is very short and brief, to just say the reason why we are here is because of history. History that so many of us here cannot be written without them. When I walked in and I saw Alan Ragi, where are you? There is Alan. Those who know Alan, please just wave. The history of the HIV response in this country cannot be written without Alan. We have Dorothy Onyangos, we have Asunta, who is absent here today, but I spoke about Alan, and James Kamau, if I don't mention your name, is because I'm on the stage, and I may forget. You know, when you're on stage and cameras are in front, you forget a lot. When everybody was trying to learn about HIV, I can see Senator Muma. Senator, you allow me when I call you Catherine Muma. I usually forget to do honorable with Catherine Muma, but I will keep for remembering. We all went through those hands. And I spoke about Alan because when I went to Geneva, Alan is like asking, do you know where Nairobi is? So when you have a conversation with somebody and you say you come from Kenya, they ask you, do you know Alan Ragi? And when you say you know Alan Ragi and you've ever shaken Alan Ragi's hand, they're like, yeah, that's my friend. He took me for nyama choma. So what Alan did is that in the early days of the epidemic, everybody was coming to learn about HIV, I think used to come to Alan and he would take them for nyama choma. Thank you for bringing tourists to Kenya. You've done well. And you made us so proud to be there at the international level and be able to be associated with the good work you did. So I'm giving a presentation and a very short speech on the epidemic, where we are today. And our role as an institution is to report on what you all do. So we may take the red carpet, but we are merely a spokesperson of the people represented here, PS. We coordinate, we bring everyone to write down the policies, we bring people together, we look at the resources available to the country, we look at the evidence. Most importantly, the county governments, we look at the program that they're implementing, and we have a bird's eye view because we then put the data together and bring it here and look quite intelligent. But honestly, the intelligent people are on the ground. So allow me to give them credit, the data, people who put that data in every day, please feel appreciated. Our job also is to make the money work, and that's a very key part of our work, and we try as much as possible to ensure that happens. So I want to remind us that Kenya has the 7th highest, largest burden of HIV in Africa. When you put India, we are number 8. Zimbabwe is below, and my friend from Zimbabwe didn't tell you that we are always caucusing with him about what decisions are being made for Africa, because we used to mistake him as a Kenyan. So at the beginning of the global politics, we identified that we would speak with our eyes. Where we are not agreeing with what is on the table, I would look at Raymond and you look at me, and we know that is a no from us. So Raymond, you can see where you are. You're not part of that list, and we do appreciate you. So globally, of course, we have about 29.8 million of the 39 million people living with HIV on antiretroviral medicines. And courtesy, most of those are because of PEPFAR program and the Global Fund, but also the fact that also PEPFAR puts money in the Global Fund. So can you all thank the US government for really coming in early enough to save lives? So Kenya is not out of the woods on that. Mupigiani Americans makofi. You know, PS, I used to work for American program, and for a long time, they never used to label their things. So one time when they said they were writing from the American people, I drove a car to the slum area, and some people came and said, we want the American money. So Brian, that is why we stopped writing our cars, but we appreciate you. We know that we get a lot of support from you. Our business model, all of us here today, remains very, very simple. We just are in the business of preserving lives. We reduce new HIV infections, we close that tap, and we have 2 taps. So we close those 2 taps. But within the pot, we have people living with HIV, and our key objective is to keep those people healthy and productive. Yesterday when we were talking to the media and we look at the work we have done, I kept turning around and looking at Dorothy Onyango, and I said, if I'm asked if you're succeeding, I actually can give evidence. Because I remember Dorothy teaching me, Dorothy is the most funniest person. So she used to ask me, umekuja kuona mama wa ukimwi? And she would come and teach me. Those days when we were writing memory books, we used to support people to write memory books so that because we didn't have drugs, so we knew they were going. And we used to organize ourselves to support the writing of the memory books. So Dorothy used to cook very, very nice food. So we used to call it the women of Wofak. So in addition to the women of Wofak who are living with HIV, she adopted the young women who had potential, who are working in different areas, and then would go and have lunch. I can see a couple of women nodding. Yeah? P.S., those days, when you are working somewhere in a bank and you are told you have HIV, you did not know where to go. So all of us would tell people, there's a lady called Dorothy Onyango. And Dorothy Onyango had found a way to travel outside the country. Alikuwa pia anatuletea stockings, yeah? So she should go to Geneva and those countries. But she molded us. She was trying to make us be who we are today. And that's why we celebrate. These gains you can see. And one of the things that clearly we can demonstrate is that we have been working. So we can see ourselves 2005, not even going further away, but when we look at what we have achieved between 2005 to 2022, we agree that we are making progress. And that is a progress PS this Maisha conference is coming to celebrate. We have moved from HIV prevalence. As an indicator on its own, it's not a good one to look at that response, but we have moved from 6.8% to 3.7%. We have reduced HIV incidence from 0.4 in 2005 to about 0.05, just like Zimbabwe spoke about. But of key importance is that we were losing about 110,000. Can you imagine 110,000 people every year? Really, those were too many people to about 18,473 last year. Mother-to-child transmission rates have remained very, very stubborn, and we are going to be looking at that as we move forward. And then new HIV infections have also reduced. So that I can move faster because of time. I know a lot of these slides are going to be shared, but I just want to point out that although we have made progress, it is not time to say the HIV epidemic is over. AIDS is not over yet, because we look at what exactly is happening in the epidemic. And when we see 41% of new infections coming from the young people, then there lies this challenge. Then you also have another challenge of children, 4,464 children being born with HIV or having HIV either through breastfeeding mothers. And that's a point we've not discussed, the role of men. I think for those scientists who are here, they know that one of the challenges we get is prevention of HIV from breastfeeding mothers, especially if you told her she was negative when she was exiting the program, when she was delivering the baby. Because we have not spoken to men about the fact that HIV is also transmitted through breast milk. So if a woman was negative and there is an accusation of infection during breastfeeding period, we need to begin to speak about it. And those are the gaps that we have to open up and bring men as partners in this area. The results are there. 78.2% reduction of new infection, AIDS-related deaths by 68%, For the last 10 years, we have also reduced HIV-related stigma, and we try to use so many measures to do it, and we increased domestic financing by 34%. Those are the indicators we measure our success on. The burden of HIV still remains disproportionate across counties. We are beginning to see a challenge emerging, and some of you can see a county there, Samburu. Uasin Gishu, Samburu, you can see there. And that is a county that is beginning to show us that when you forget a location, you begin to see a challenge. We watched Turkana County for a long time, and just like we are seeing Samburu, please let's go back to Samburu. And Brian, I hope you get partners to go back to Samburu. We are asking, let's find out what actually is going down there. And when Sheikh comes, you're going to see that actually the challenge with Samburu is also linked to the adolescent girls and young women. We have spoken about the targets. I want to say that although we made progress, we had committed that we were going to reduce new HIV infections by 75% by 2020. We did not achieve that target. So that is something that we keep in our mind that we were not able to achieve. And therefore, 2030 is something we have to really work hard to reach there. We also have that challenge of the younger generation, not only adolescent, but the 34-year-old and below. And this one is a concept that we all know of serial monogamy. We must start beginning to see, as the dating experiences start, what's going on with these younger adults. Are we really trying to give them the correct information? The subpopulations, the men who have sex with men, people who inject drugs, we have discordant couples, the fishing communities, the sex workers, those are also population we must continue to look into. Pockets of new infections, of course, I have mentioned Samburu, even Uasin Gishu County, we know that's something that we can attest to, but what we can see, I think there is a change in the sexual patterns, and we may have to look into that. We missed the target of mother-to-child transmission of HIV. We were expecting to go to less than 5%. Lakini Siaya County. Siaya County mko? Siaya. Kuna mtu wa Siaya? Situkupigia makofi. Hiyo tutaimba wimbo. Siaya County did us proud last year, and they showed us it's possible for a high burden county to actually go below 5% transmission rates of HIV from mother to child. So we hopeful that we can really change. I also want to point out 67% of the cases we are seeing from mother to child transmission of HIV, of course, are from pregnant and breastfeeding mothers who are not on ARVs, that's 35%, and those who have their treatment interrupted. We have, those mothers are too few for all of us here today. We have to support them and find out why they are dropping off the medication. We committed to have diagnosis of both HIV and syphilis, but we can see syphilis is also being left behind in terms of diagnosis, and we only were able to test 85%. My brother here, Dio, just talked to us about health systems at work. We have to have a health system. If you're giving a mother diagnosis for HIV, then we're also giving the diagnosis for syphilis at the same time, because we know that the impact of syphilis on an unborn child is really not desirable at this particular age and time when we know we can prevent. 94% of people with HIV on antiretroviral therapy, we are so privileged, and we also are happy because we know this is a target that we should really achieve 100%. However, we need to find out who are the 6%. What kind of people are we leaving behind? And the members of parliament here yesterday, when we say we have left behind 6%, you have really likely saw something. Those could be the people we are talking about. It may be the people who are hidden somewhere, who are not in our faces, but they really need our services. So it's important to do that. We have been told children are being left behind. Only 10 counties are achieving coverage of about 95%. And so we have a challenge there around children. Viral suppression is an indicator we check to see if you're doing so well on treatment, because it's one thing to put people on treatment and another to establish if the viral load is being achieved. And only 12 counties did achieve, have people living cohort or people living with HIV achieving 95% treatment. AIDS-related deaths have reduced, but we also are noticing that we are leaving adolescents again behind because the reduction of AIDS-related deaths is low. I want to congratulate the PEPFAR partners, the people who have come up with that brilliant program of Operation 000. I think that is an initiative that we should scale up across the country, where we are empowering adolescents, the children we lied to. Unajua tulindanganya watoto, na ndio ni ukweli. Tukawadanganya wanakunywa dawa kwa sababu wako na holes in their heart. Because of stigma, we lied to those children. Now they are adolescents, and when they learn the truth, the first thing they do is to stop medication. So we want to correct our mistakes and put them together, empower them to reach out to each other so that they can stick on treatment. And that Operation 000, I am convinced, is the way to go. When I spoke in the last meeting in Nakuru, one of the young people from that meeting, I spoke about Maureen. Where are you, Maureen? Maureen Murenga, lean on me. I don't know where she is. She probably is not here. She's doing global politics. So I told them that it's not only them who are left when they are dating, the ones living with HIV or born with HIV. I shared with them with the story about Maureen telling me how she was dating somebody, and when she told them that she was HIV positive, they abandoned her in a restaurant, and we always laugh about this. So when I shared this small story to these girls, they came and told me, so you mean that's okay when somebody rejects me, it's okay? And I said, yes, that person was not meant for you. So what we are saying is that this group of adolescent children who are born with HIV, have lived with HIV, they require special attention from us. They require us to look at their mental health, to look at their self-esteem issues, but also address them as they enter from childhood to adolescent and to adulthood. We need to be prepared to answer questions, but also give them the support that they require to become adults that are responsible, as well as taking care of their own health. I want to also point out that we usually used to say we have a mixed epidemic or a generalized epidemic, where most counties were experiencing HIV new infections coming from across the general population. But now 22 counties, HIV infections are coming from groups that are either sex workers, men who have sex with men, or people who inject drugs. This is something that we are trying to look into and guide counties on what to focus on. If you have a concentrated epidemic, your program for key population must be very, very strong, as well as now looking at the general population through the women who are pregnant and the mothers who are lactating. For mixed epidemic, a lot of that is because there's a lot of infections with adolescents, but also key population. And then generalizing epidemic is where everything together is. We have done well at the key population program. I want to sincerely thank the men who have sex with men, the people who ingest drugs, and the sex workers who came at the table to challenge us and to tell us, do not program for us without us. And the results have been seen. The contribution was about 33% in 2009, and now 2020 was about 13% of the infections from that group. I can attest to the fact that our female sex workers have been very instrumental in the results we are seeing today. Female sex workers, mko. If they are here, they know that they have been our voices to talk about condom use. They have also been our voices to talk to their peers and try to make sure that we do not have new HIV infections being contributed from that cohort. I want to move faster. I can see, and this is how we have gone with the key population program, how we started. We have hosted very many delegations. I think this year we've hosted about 7 countries coming to learn from Kenya. And what is interesting is when they exit, they give us new issues to learn from, especially on our people who inject drugs. The reason we are where we are, Mheshimiwa, is because when South Africans came, they point out an issue, they see our strength, they tell us if you can improve here, it's a good thing to do. When Zambian came, we have visited Mozambique, We have hosted Uganda, and the list goes on. Tanzania, they keep coming to see the good work you're all doing because that is your work. And this is one of the programs that really has been instrumental in providing us those results. We are still far off from closing the resource gaps, and that's why Zimbabwe was invited. Zimbabwe, that AIDS levy fund, we want to understand it, we want to see, although we brought a delegation there before, we want to see how do we learn from a policy direction that has ended up giving you results. So we want to learn from how to tap that kind of resource. So quickly, our gaps, and I will just mention them before I invite Sheikh. Of course, our largest gap is the issue of HIV and health outcomes for men and boys. We are seeing, of course, access to diagnosis for men and boys is lower than that of girls and women, but also the number of AIDS-related deaths among men. If I ask most men here, the last time they thought of going to a hospital setup, they actually don't, they can't remember unless somebody has a chronic illness. So we find it very difficult to find men early, and most of the time, the only place we find them is the tuberculosis clinics, and that sometimes is too late. They have lived with HIV for too long. We have to address the determinants of risk and vulnerability, and here the issue of drug use and especially injecting practices is very important for us. We really are looking at prisons, and we had a meeting last week with the people from prisons because something is going on. This is the population we are having, and that is why we are talking about when people are crossing over from from outside to the prison. What actually are we trying to do in the prisons to ensure that there are no new infections coming out of the prison, but also the people who go to the prison who are HIV positive are adhering to their medication, and when they come out, they actually have maintained their status. We have to look at the new proven prevention options, and that's something that we are trying to work on and adapt and bring to scale all other high-impact interventions. I know young people yesterday were talking about, can you make sure that you have the multi-purpose vaginal ring? And I said, I have handed over to the PS. So, because we must find resources to invest in this really working technology. This is a scientific conference, and one of the things that we're going to be discussing across the week is all this new technology that either has been in development, preclinical trials, and the ones that are currently available for use. The other area is, of course, addressing the overlapping challenges, which I'm going to invite Dr. Sheikh to take us through that. The adolescent and young people, 18% of people who are attending ANC clinics being adolescent aged 10 to 19, and 36% of our sexual and gender-based violence cases being children. You know, child mothers. We have visited 26 counties, and every time you go, we meet child mothers. It's not very, very interesting, especially for the child mothers who are told they are pregnant and they have HIV. I know most of the service providers here know how difficult it is to start telling a child how to prevent HIV from her child whom she's carrying, and sometimes without knowing about the pregnancy. And this is where we are trying to put in a program that allows everyone to come in, because this issue is not just a health issue, it is beyond health. I said I'll speak about Samburu here. We talked about Samburu epidemic. If you come down here, when you released the Kenya Demographic Health Survey, you find Samburu was again leading. 50% teenage pregnancies. So you can already see the sexual encounter when girls are young and how that is now coming back to get us to HIV. And that is why we said that we cannot just stand to talk about HIV without looking at these other areas. Prevention knowledge, again, we were very surprised, most of us that said they were surprised that young people did not have the knowledge on how to prevent themselves from HIV, and that's something that we are looking into. Is it that we are speaking to ourselves? Can this money work differently? Even the resources available could reach the young people. So with that, allow me to invite Dr. Sheikh to take us through very few slides on what we are working with the National Council for Population and Development around bringing together the HIV movement and the development sector movement. Dr. Sheikh is not new to us. He is also our own person from the health sector whom we gave to the Ministry of Interior, Ministry of Finance, Planning. No, Finance, yes, Ministry of Finance. And I just was talking to the PS and we were saying maybe you should recall him so that he can come and do these things in health. Karibu, Daktari.
So let me just also observe the protocols. Our chief guest, PS Harry Kimtai, the PS State Department of Medical Service, the governor of Elgeyo Marakwet, His Excellency Wesley Rotich, the Vice Chair of Health, the members of Parliament present, the Board Chair and the CEO of NCDCC, our development partners, good afternoon. Mine is just very simple, PS. I'm just here, you're wondering why NCPD is here. I just want to, first and foremost, to give you a summary of what I want to say. I was just invited to talk about the triple threat. The triple threat is about HIV, teenage pregnancy, and the gender-based violence. Those three are what we're calling the triple threat, and I'm just going to give an overview of why those three things are very important. I'm from the National Council for Population and Development, NCPD. I know it's noon, it's around 1 o'clock, and I can see many people are praying. So for me to interrupt that, I just want you to say N triple threat. End HIV, end teenage pregnancy, and end gender-based violence. PS, in 2019, there was a conference that was held here in Kenya, in Nairobi, and this conference was 25 years after similar conference was held in Cairo to commemorate an issue we called ICPD, International Conference on Population and Development. The aim of that conference was to look at population issues in very many dynamics. But the things that were picked was this issue to do with reproductive health. And in 2019, Kenya made 17 commitments. Among those 17 commitments was to end gender-based violence, to end teenage pregnancy, and also to end maternal mortality by 2030. PS, Kenya aspirations, long-term aspiration is to have quality population. When we got independent in 1963, our focus was more of managing population. Currently, our focus is not about managing population, our focus is about quality population. In 2063, when we're going to celebrate 100 years, Kenya will be over either 87 or 100 million there, about. But what we are saying is not about the number, it's about the quality of the number. And currently, our average age as a country is around 20 years. In the Western countries, mostly I think they're about 40 years of age. So Kenya will also transition into that demographic transition. But then there's this, what we call the window of opportunity, the window, what we call the demographic dividend window. And Kenya has to harness that window in the next 40 years. 2063, when we're going to celebrate 100 years, then we will know whether we have harnessed this demographic dividend. What does demographic dividend means is we have reduced our fertility. Kenya is around now 3.3. Our fertility is around 3.3 from a figures of 6.7 in I think in 1989 to 3.4. That's a good figure. Our population, if you look at our dependency ratio, it has gone down. If you look at our life expectancy, we are talking about an average of around 65 life expectancy. So we're doing so well as a country. We have progressed very well. Not doing so well, but we have progressed. But our target is to reduce dependency ratio, to improve our life expectancy, just like Western countries. And the other thing is to have quality population for us to harness that demographic dividend. This youthful population is affected by many factors, and among those which are affected is about teenage pregnancy. And that's why here, we looked at, as a council, the National Council for Population and Development, issues of teenage pregnancy as something that will hinder our demographic, what we call our development issues. And peers, when we looked at the issues of teenage pregnancy, it is implemented by very many institutions, the Ministry of Education, the Ministry of Gender, the Ministry of Health, name them. But each one is just looking at one specific intervention. If it's education, they're looking at how many have dropped out of school, how many are coming back to school. If you look at health, they're looking at the maternal mortality, they're looking at ANC, but they're not looking this one girl just in a holistic manner. And thus NCPD was picked to spearhead a program of ending this teenage pregnancy. And we brought in, together with my sister here, Lebon, we said we need to have a multi-sectoral approach. So we have a multi-sectoral coordination at the national level, spearheaded by PS, State Department of Economic Planning. And then we also have a multi-sectoral coordination at the county level. So today mine was just to sensitize you and create awareness about this campaign. And this campaign moving forward will pick and will become more stronger. So we really want your support. But why are we focusing on this? Is just, I don't know what's happening this. It's not moving. Yeah. I don't know, someone can help me on this? I don't know, it's not moving. Actually, help me to move this. So if you can move, look at that. We are talking about the triple threat. It's just sexual encounter first, but then there is, this we're talking about adolescents of 10 to 19 years. First sexual encounter, and then there is pregnancy, which leads to HIV infection, which can also lead to sexual and gender-based violence. Why is this again? Next slide, please, if you can run it from there. Next slide, please. And this is what we are talking about, the multi-sectoral approach. Because there are two things we observed when we were looking at this program of ending HIV, teenage pregnancy, and the gender-based violence, is the way we're running as a government. Really, sometimes we do programs, but sometimes it is not coordinated very well. And that's why we came with this multi-sectoral evidence-based initiative that adopts a whole government approach to enhance commitments and accountability towards ending the HIV infection, pregnancy and sexual and gender-based violence. Next, please. The triple threat, if we look at it in terms of why it's important, look at it in terms of figures. HIV costs us around more than 25 billion annually. GBV is around 46 billion is required to respond and manage sexual and gender-based violence. 17% of a GB is lost due to lifetime cost of adolescent pregnancy. And yet, if girls in Kenya had completed primary school alone, the additional output over their lifetime will be equivalent to 20% of the annual GDP. At household level, the triple threat perpetuates cycle of poverty. And that's why we picked, if I just give you one history about HIV. In 1989, NCPD was the first institution to develop the multi-sectoral response and an advisor on HIV, 1989. That time even NAC was not formed, PS. So NCPD picked this program and they highlighted issues to do with HIV as a threat to our population. The same way PS, today we are picking issues to do with gender-based violence, HIV, and the teenage pregnancy combined as a threat to our youth. So if you look at it, teenage pregnancy is a priority indicator of heightened risk to HIV infection. Its sexual and gender-based violence increases the risk of HIV, and pregnancy among adolescent girls is often associated with negative health and social outcomes to both the mother, the baby, and may lead to intergenerational cycles of poverty, poor education, and unemployment. When compared with older women, adolescent and young mothers have worse HIV-related outcomes, including high infection rates of HIV during pregnancy and breastfeeding and lower rates of retention in HIV care and treatment. Next, please. So the purpose of triple threat is to build resilient, to facilitate enabling environment, and to enhance system of reintegration for sexual and gender-based violence, and facilitate coordination across the government. Next, please. Look at that figure. In 1989, our teenage pregnancy was 25%. In the last KDHS, it is 15%. That's a difference of only 10%. It's only, they say that it's only a fool that does the same intervention and expect different results. If it took us more than 30 years to reduce teenage pregnancy from 25% to 15%, and we want to end teenage pregnancy by 2030, that is 7 years from now, I don't think with the same interventions we can achieve zero results. And that's why really we need to change the approach, and so that we can have this multi-sectoral approach, one government approach to end teenage pregnancy. And that's why I just put that graph so that we need to go from 15 to 0%. Next, please. Then this is a roadmap we are coming up with. We're going to have meetings of PSS, just to share what we have done so far. Last year we had a conference here in one of the hotels in Mombasa, where we convened all the county commissioners and the regional commissioners. If possible, PS, we want to do for the same for the governors, and the governor is here, so that this thing can be taken down to the county level. Next, please. The thing we require is bold leadership and accountability. We require common objective and defined responsibilities, multi-sectoral engagement and partnership, and leverage on domestic resource and infrastructure, and leaving no one behind. PS, resource is not a problem, it's just a coordination. Two things we have observed: multi-sectoral coordination, information, awareness creation. If we just invest on those three, I can assure you these things PS can reduce. So the approach is one, promote bold, cohesive. Please go back. The approach is promote bold, cohesive, and accountability leadership, unify around shared objective. Go please, next. And then also harness domestic resources and establish mechanisms to build sustainable partnership for intersectoral or intersecting triage challenges, and embrace and leverage technology and innovations to end teenage pregnancy. The triple threat dialogue is ongoing. The NCDC, the NAC, former NAC, has organized campaign across the 47 counties. I think right now we have covered more than 7 counties, and we want to take this thing to the 47 counties. So please join us today in this campaign. I'm told here we are around 1,000 people here. So if you are representing any organization, please take this message to your organization, to your institution, to your county about ending the triple threat, ending HIV, teenage pregnancy, and gender-based violence. Thank you very much, and God bless you.
Thank you very much. PS, that's Dr. Sheikh. The last time we worked, we were playing football. We played Governor Rotich. We played football from all counties, and we brought the best winning team to State House. So even this one, we shall do and deliver, because all these people seated here will become members of the club and the triple threat. So with that, allow me to invite a special guest, the last speaker on the technical side, Honorable Senator Catherine Muma. And Honorable Catherine Muma is coming to speak to us from a parliamentary perspective on then what we do. We have been fighting about this issue of adolescent. Some say it's comprehensive sexuality education they do not want. Others say it is services that they do not want. But what is common amongst all Kenyans is that from a parent to a teacher to a religious leaders, they agree around one thing: they have a problem. So at least tunaweza jipigia makofi. So when we get 260,000, 300,000 teenage pregnancy, when we hear 600 children are taking exams in maternity wards, tunakubaliana iko nini? Shida. So what is the problem? Now, the problem comes tukianza kusema, what is the solution? That is where we start now becoming factions. Faction A tells Catherine they want something else. Faction B says, mimi na watoto wangu sitaki mufunze watoto wangu. I would be the one to teach my children. And I want to say before you come in, Catherine, you know, I am a mother, and I'm a very open mother. And my daughter, my firstborn daughter, told me everything, everything. You know, she used to tell me, mommy this, mommy that. And so she finished high school and she joined the university, and we were talking about everything. And then one day, as we were driving, she was learning how to drive. She said something, then I said, by the way, I hope when you want to have sex, you'll tell me. Then she kept quiet. I said, have you had sex? She kept quiet. I said, whoa, lo, 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 lo. So I said, are we talking that we've had sex? You know, now I'm becoming agitated. I'm sweating. This is the baby I've been talking to, and I'm waiting for her to tell me. Then she answered me, did you tell your mother when you had sex? And that is the only answer she gave me. But I pushed forward and I said, was it having a condom? You know, because now I'm imagining the answer she's giving me, it is yes. Then she said, we did not even discuss if I had it before, so stop pushing further. Mom, full stop. Catherine Muma, that is some of the issues we are facing.
Good afternoon, everyone. The Honorable Chief Guest of the day, Mr. Harry Kimtai, PS, State Department of Medical Services, Excellency Governors present, honorable members of the Health Committee from the National Assembly, led by the Vice Chair, Honorable Munene, Dr. Ruth Libon, distinguished guests, communities present around, all protocols observed, ladies and gentlemen, allow me to thank the NSDCC for inviting me to come and speak at this conference. I will not speak to the HIV prevalence issue. I just want to speak for adolescents. And my topic is about adolescent health. And I want to focus on adolescent health because I believe the challenge we have even on MTCT will be resolved the day we address the issue of adolescent health. And I'm calling it adolescent health instead of adolescent pregnancy because if we acknowledge the health, the holistic health situation of children and adolescents, then we will not have to speak about pregnancy. We speak about pregnancy because we are being reactive. We have allowed it to happen, and now we want to deal with it. We need to get back to the drawing board and ask ourselves serious questions as a country, as leaders, and therefore my paper is calling us to account collectively as leaders in the political realm, in the executive, at the national, county level, within communities, religious leaders, and all the others. Now, adolescence is that period that signifies the stage of transitioning from childhood to adulthood and is marked with a lot of physiological, biological, and other changes that impact the life of those affected. It impacts them mentally, psychologically, and emotionally. It is a stage of life that every one of us has gone through, and we all agree that it requires support in order for proper transition to happen. It is a pivotal phase of human capital development, and therefore, the opportune time for us to teach and reinforce fundamental values and beliefs. But it is the one stage where we have spent years arguing as to what to do that is right. Beginning with where Ruth left, our cultures do not allow, have made it taboo to discuss sex with your children. And I understand, because it did not happen during my time, that aunties and grandmothers are the ones who taught sex education. But when I have inquired further, I found that it wasn't really sex education, it was how to please your husband when we get married. They did not tell you about what are the changes happening, what is this menstrual-related cramps, how do you deal with these diseases that happen, what happens if you get an STI. That conversation was never there. It was about how you will be a good wife. And for the men in communities that circumcised, it was how best to be a man. And now all women belong to you because you are now circumcised. You can go on the rampage. So I have done the homework to find out, did we have sex education, the kind that in our debates we are saying we need to go fall to in order to help our children? I have come to the conclusion it really wasn't there. And I want to admit, like her, I did not know what to teach my children. I went to a school where I was told it is parents who must teach sex education. I said, but I was never taught, so what does it entail? And I forced the school to organize a session for those of us who didn't know to give us some education. But by the time I was done, it wasn't sex education either. It was just a moral lesson on putting the fear of God in a child, telling them not to get pregnant and not to get HIV. That is not sex education. And I think if I ask you to raise hands, I will not ask you to raise hands. Most of you will believe all you have ever told your kids is put the fear of God about HIV and pregnancy. But we didn't tell them much. So I am here today to tell us that the data that is coming through is telling us that we are killing the nation if we don't do anything about adolescent health. We have approximately, I think, 11.6 million adolescents in Kenya, and 50% of adolescents are apparently active sexually before they attain the age of 18. Most of these children lack accurate information to guide their decisions during this period, and this is evidenced by the disturbing statistics around pregnancy. 2.3 million adolescent girls attended antenatal clinics between 2016 and 2022. Of this, 143,502 aged 10 to 14 years. But when you look at KDHS, it gives us information from age 15 onwards. We've even decided to pretend they don't exist, even though the facilities are telling us they are there. So why are you worried that we will not have a problem with MTCT? How can a 10-year-old with a child understand the value of MTCT, or a 14-year-old? So the problem is that we allowed the 10-year-old and the 14-year-old in the first place to get pregnant, even the 16-year-old. And we must call ourselves to order and do something about this issue. Now, how come we have all these people pregnant? If you look at our criminal laws, sex with a child is defilement, isn't it? So basically, we are talking about 2.3 million of our children have been defiled. But now when you go to the law and order sector and the justice sector, less than 60,000 reported cases of violence and far less cases going on in courts. What does that mean? It means millions of cases have gone unattended to because we have normalized violence, we have normalized defilement. And where is this defilement happening? It is happening in the families, it is happening in the communities, it is happening in the churches, it is happening in the religious spaces, in the schools. But we have chosen to keep quiet about it. That's why we only record less than 50,000 and we have 2.3 million pregnant children. It means we have gone rogue as a society and we need to do something. And then, of course, we've received the statistics on HIV. So if children are pregnant, it means there was unprotected sex, and therefore many of them, and they don't have that sex education, they will be infected. And if the sex continues, there is cross-infection that is going on. So why will we not have a problem? The HIV figures will start going up again because we are not doing anything about this. And then there is a problem, the legal problem of definition. Adolescents are children, but they are also adults. So in the health facilities, a 14-year-old cannot walk in and be given services. They'll be told, bring your father or bring your mother. They must have an adult with them before they get services. But there is the paradox. If the child gets pregnant, we are willing to see them without the father or the mother. So there is the legal contradiction that makes it impossible for the health service providers to attend to these children, to pick what's happening with them, to treat them, and it's not only girls, even the boys are not being treated for STIs because they will not walk into the facilities and get services. So what is happening, Mr. PS? There is a parallel health system of quacks taking care of the adolescents because we are not taking care of them. So they are able to go into a shop and somebody calling themselves a doctor who is not a doctor, who gives them the so-called P2, who is ready to do abortion for them, and many of them are dying, many of them are being messed up. Why? Because our legal definition and the ambiguities around the child in the health system is actually making it impossible for this child to be able to get services. So what am I saying? I'm justifying Dr. Mohammed's proposal that the triple threat has to be addressed. But in my view, it is not just the pregnancy for the adolescents. We actually need to redefine adolescent health in this country and do better than we have done. And how do I think we can do this? We need to begin with a conversation among key actors for a comprehensive national policy on adolescent health. Why am I saying so? I have actually read the myriad of policies that we have in the health sector on adolescent health, but they are dead policies, they are paper policies. They are not being implemented because everybody is scared. The bishops are not going to allow us to do this. How can we move this? So we have policy upon policies that are not being implemented. So as far as I'm concerned, we don't have a policy. We need to have policies that will bring around the table the health sector, the education sector, the law and order sector. We need Professor Kindiki to tell his chiefs that they cannot allow defilements to happen in the homes and then they say watu waongee nyumbani. We need to actually deal with those issues. We need the Attorney General around the sector. We need the gender department to come around the sector so that we can decide how are we going to help these children. And the beginning place, whether we like it or not, is sex education. I know the word comprehensive sex education is stigmatized in Kenya, but let us sit down and decide how does sex education look for Kenya. If sex education elsewhere is immoral, let us define the morally correct sex education in Kenya, and the best space for that to happen is the school. It can't be elsewhere. I have 5 children, and none of them came with a manual on how to raise them. So I was never taught how to teach these children sex education. So to pretend that parents will know what to teach their kids is kidding ourselves and is killing these kids. Let us define, let it be put in the schools. Let the parent who does not want that to happen sign off, but let the other kids actually be taught. It is important that we do this. And one way of doing this is also to ensure that you bring that multi-sectoral team to then define the tenets of what that curriculum will be. Secondly, we need to recognize we also have out-of-school children who will also need to be educated. So we should develop the relevant IEC materials, use other forums and mediums to deliver the same education. Thirdly, I think our medical schools need to reorganize their curriculum so that we can have adolescent health medicine. We have pediatrics and we have gynecology. So this child is 10-year-old and she's pregnant. The pediatric doctor does not think it is their role. The gynecologist is getting embarrassed around dealing with this 10-year-old. We need to recognize that the development of a human being means that we might want to specially study the lives of adolescents and create adolescent medicine. so that we actually specialize in that. I'm suggesting that we revise the Kenya Demographic and Health Survey data collection parameters. Why are we picking? The health facilities are telling us that we have 143,000 is a lot of people, 10 to 14-year-old who are pregnant. But we proceed to only factor the 15-year-old going up. And if it is not in the survey, as you know, it can't be in development, it cannot be planned for. What are we doing? We are killing these kids by not planning for them. We need to decide, how do we factor that age group that has not been in the KDHS? I think we need to revise our universal health coverage and the National Insurance Fund regulations to ensure that adolescent access to cost-free healthcare services. And these healthcare services should include HIV and STI care, HPV vaccination, management of menstrual period-related conditions, fistula repair, and reparative procedures for issues related to FGM. FGM can actually, some repairs can be done in terms of FGM, and I think any child who has been circumcised against their will needs to be able to get any help that they can get. We also need to establish a policy to assist in detecting and prosecuting sexual violence within families, communities, and other social environments. We hardly follow up on issues of incest, and every time there is a report about a boy being defiled in a church or a girl being defiled in a church, we hush up that story. We never follow it up. In fact, most churches don't even have sexual harassment policies that can actually protect members. We need to start openly discussing this. And then we also need to review the Romeo and Juliet scenarios where you have adolescents having sex with each other, but many boys are being arrested for defilement when they themselves are young. There is an issue there that we actually need to relook at and look at this. And then finally, we need to invest resources. Mr. PS, the health budget needs to have specific resources that will address the issues we are talking about, the conference issues of HIV and TB, so that we are not largely dependent on development funds. We need to have local funds in our budget, and I am also calling for specific funds to deal with adolescent issues. Thank you so much for listening to me.
Thank you very much. I think DJ, that one would have deserved the clap that is done in a nice way. Catherine Muma, of course, has challenged all of us as parents, as policymakers, as people who've been in this field for a long time. And I know that indeed, she is leading that discussion in Parliament, in Senate. And for us in the health sector, we will take your paper. I'm told that it was tabled in Senate. You read it in Senate? So we'll take it and share with the PS, and we'll be able to see some of the areas that we can also begin implementing. Let's give her another round of applause. Thank you very much. And at this juncture, I would like us to invite Bosire back on stage. Okay, thank you very much. I am told that we continue with the program, and at this time, PS, allow me to invite the chairperson of the Health Committee, represented here by Munene, to make his remarks, and thereafter we will have the governor make his remarks. and then we'll have a short ceremony, which we are having an award ceremony, and then we listen to your keynote speech and conclude the afternoon. Karibu sana.
Thank you, Asante Daktari Maisha, CEO of Epidemics. PS, Bwana Kimtai, Chairman of Epidemics Council, Governor rafiki yangu, all leaders present, the partners, all stakeholders of this forum, good afternoon. My name is Munene. I'm the Vice Chairman of the Audit Committee in the National Assembly. This is the second term I'm serving in the Audit Committee. I served in the Audit Committee again in the last Parliament. This is the second time I'm coming back to Parliament, but now as the Vice Chairman. I want to thank Senator. I was listening to you too keenly, but you touched my heart as you were finishing your speech on the boy child issue, because we had that problem in our county last week, where a 17-year boy was married to a 14-year girl, and the boy was arrested and taken to prison, and the girl was rescued. So I was asking, who will rescue the boy? So I think the boy stayed in prison for almost 1 week before there was a lot of outcry on the boy child, and we decided the boy needed help too. The issue of sex education is not only a problem to local communities, it's also a problem to educated people. PS yesterday, I appeared on TV with the CEO as we laid ground for this conference, and I was trying to explain why there is so much HIV associated with people who take cocaine and heroin. So I was trying to say that cocaine and heroin are stimulants. So people who use cocaine and heroin are very sexually active, more than people who use alcohol. And immediately after the show, the first call I received was from my wife. And my wife is a health worker, and she was too mad at me. She told me, you could have used more disciplined language. Why do you go say having sex? So even now, PS, I don't know how I'm going back home. Nataka hii seminar iendelee kidogo ndio nikute makasiriko imeisha kidogo, because I used bad language. I humiliated her. So this issue of sex education, it's a big problem, PS, kwa sababu tunataka kuendelea kufunikia mambo badala tuongee. I have a speech here from my chairman, Dr. Pukose, who is not here with us because he is with the president in the tour of Western Region. But I won't be leading it because I'm not a believer of speeches. I've written speeches. I love speaking from my heart. I come from the school of politics and the thoughts of Rigathi Gachagua, where we speak from our hearts. Kwa sababu hii kizungu nyingi imeandikwa hapa yote, hii nitaachia specialist, hii ndio mambo mtafanya kwa hiyo mikutano yenu. All the forums mtafanya, zile boardroom meeting mutafanya, you discuss all these facts. So I don't want to start bowling with you without the epidemic transitioning of how we are at 18%. You know all those things. There's the 7th Maisha conference. And these are things you have been discussing. So I don't want to read the figures for you. You can check them online. Even if you Google, you can find them. So I might wait for you 1 hour here trying to read for you figures of how many people are HIV positive, of how many children. The important facts for the planners are those who make policies, but me as a politician and as a leader, I want to speak from my heart. Because I listened to young people yesterday on the TV show who appeared on the TV show after we were done with the CEO. And those young people, men and women, list very key issues. One is how we communicate to our young people on the issue of HIV. How do we communicate to them? Kwa sababu we want to go back again. Ndio tulisema jana, in the 80s, in the 90s, people were scared of HIV because they couldn't see the effect of HIV. But now with the ARVs and the treatment, you can't see very serious effect of HIV. So the young generation don't know HIV can be serious. And we can't go back to that. I wouldn't want to go back to that. So now we need to craft new communication that rhymes with the young generation. Because I want to tell you, PS, the young generation, I was young kitambo, saizi I'm not young anymore. So sijasahau vile tulikuwa tunabehave tukiwa young. The most dangerous thing for a young person is pregnancy. It's not HIV. HIV is not a problem. And I want to tell you, PS, young people eat condoms. Hawapendi kabisa. The young generation does not have condoms. So we need, what do we do? What do we do about these young people? Because if we continue with the trade, and we end up with a young generation that is HIV positive to those high levels, it will kill our economy one day. Hatutaenda vizuri. When I left university, my first employment as a young man was with the Ministry of Health. Then the then CEO for National AIDS Control, Professor Alois Olago, visited our place then. And I spoke very well about HIV. So he said this young man should be made the coordinator for HIV in this constituency. I didn't even have a personal number. So after getting employed by government today, in the next 2 months, I was a higher holder and head of department. I was promoted very quickly. And then I became very active on HIV. And the impression then was, if you see somebody very active on HIV activities, he is also positive. And those were times I really needed a girlfriend. So even getting a girlfriend became a problem. I really needed one then because I was not married. So it became a problem. Naongea na msichana, after around 2 weeks, naona ameanza kupiga kona. Aniambie shida ni nini. Naanza mwingine, tukimaliza miezi 2, anaruka. Kwanza tukifika ile mahali ya kunegotiate the important topic, anaruka kabisa. So I was wondering, what is wrong with me? Until somebody told me, you know, the discussion in the village is, ni vile ulipata ukimwi huko shule, ndio ukapewa kazi ya ukimwi. So I got very stressed, nikashindwa hii ni kazi nimetafuta ina gani. So I got one woman akaniambia hapana, mimi nitakushika mkono. I hold your hand in this. She held my hand. Tukaanza kufanya mikutano na yeye. Nikienda mikutano namwambia simama kwanza useme hiyo maneno ya HIV. And that woman is seated here today. She is my coordinator in the constituency of HIV activities. She's there. This woman is a hero. She's the one who demystified HIV in our place. And we were able to talk about it. And so when I got elected as a member of parliament, I thought the only thing I can do is to bring her now so that we can do this together. And she's doing very well at it. PS, we've been challenged to put money as a country, what Senator said, because we can't be so much donor reliant. And the president has been very categorical on this, that this country won't continue relying on donors forever. So PS, I'm challenging you. We know our finances are constrained, but let's start in a small way. Let's start in a small way, also urging our donors to stop withdrawing from us so quickly. This impression that Kenya is a middle-income country has made donors pull out very quickly. They are cutting on the donations very drastically. And if we go that route, we may end up crowing back on the gains, on the achievements we have made. And we have made serious gains on HIV, on TB, on malaria. But now if the donations and the help goes down so drastically, so PS, because of the one who sits in the negotiating table, I would urge you to engage our donors that it's okay, we are continuing to improve our financing. And even as Parliament, I give a commitment today, even on behalf of the Health Committee, because we are the ones who do budget financing for health. We'll add more money. Senator will put money to those programs. We'll put money to those programs. And finally, yesterday, I want to talk from what I saw yesterday and from live experience. That's why I'm not reading this speech. Because this speech, when I look at it, it's talking about our The three key shifts that Kenya is facing: the epidemic transition, coming to the young generation, the donor transition and decline of external resources, the demographic shift, they are the problems they are discussing. Yesterday, PS, we went to a program that has been very well structured by NASCOP and the Epidemics and NACADA people. It's a model program. So I want you to go there. Before you leave Mombasa, get time and go there. It's a model program. But I realized we have a main problem of drug abuse in this country. There are drugs that have been taken as acceptable in this country. Because I approached one of the ladies there, she was just preparing heroin. So I asked her, when did you start using this, mami? She told me, you know what, mheshimiwa? Mimi hata sikuwa natumia mihadarati mbeleni. Mimi nilikuwa natumia bangi tu peke yake. So nikashindwa. Bangi is normal. Hata bangi is normal. Hakuwa ameanza kutumia mihadarati, alikuwa anatumia bangi peke yake. Sasa akatuambia baka I started having headache if I don't take a certain type of bang. That's when I realized the bang I was using was laced with heroin. So wakati alikuwa anakunywa ile bangi ya kawaida, hiyo ni kawaida. Hiyo statement nilitoka hapo nilikuwa nimeshuka sana. Nikashida, yani tumefika hiyo level yenye sasa bangi pia imekuwa ni kawaida, haujaanza mihadarati kama hujaenda hizo zingine. So I saw that as a major problem na nikaona tuko na shida ya drugs. Then PS in that program I observed, and I want to thank that gentleman there, Talik. That gentleman had done a lot of work there. Because approaching those people and making them trust you, huyo ndiye alitupeleka huko. Ukienda huko bila yeye utafukuzwa. Now they trust him, they say he helps them. Because PS you go, we went to a place, we have over 200 people, and out of these 200 people, hakuna mtu ana cocaine yake kidogo na heroin yake kidogo. Anakuambia hii tunanunua 250, hii tunanunua 500, hii ni expensive, ni 1000, and they are preparing it open. Rebecca County Commissioner anamuuliza, hii unakunywanga mara ngapi per day? Na ni cocaine. So nikaona the program is good, but we need a double prong approach. As the ministry tries to rehabilitate these people, because the rehabilitation program is important, we need to rehabilitate them. As the ministry proceeds with that program of rehabilitating those people, the internal security at government must know where these drugs are coming from. We must crack on the source. It's too much, PS. I was even ashamed. I wondered, am I in a country with a government? I'm studying here as a member of parliament, discussing with somebody, hii cocaine ulinunua pesa ngapi? Mnatoanga wapi? Hii ni cocaine ama ni heroin? Ananiambia hii ni heroin. Nilitoka hapo nikashindwa, mimi naishi nchi aina gani hii kweli? Mnanielewa, good people? So I support the program, we rehabilitate them wale washaingia kwa hiyo kitu. Lakini hakuna haja tunaendelea kurehabilitate na cocaine bado inaendelea kukuja Kenya. So are we trying to inakaa hii cocaine tunaleta ni kama we are also concerned about the sustainability of the project. Kwa sababu ikiisha project itakufa. So PS, we must crack the whip on the source of this cocaine and heroin. It's too much. It's like this issue of beer, PS. The illicit liquor in this country, the biggest problem is illegal ethanol. And we know that. It's not difficult for the government to find where illegal ethanol is coming from. So hata tukiendelea kushika wale watu wako na virabu kidogo wanatengeneza tupombe huko, wacha pia tumalize hii source ya the source. Let's crack the source. Finally, mimi nataka kushukuru the organizers of this forum na kupeana commitment as the head of the Health Committee in the National Assembly today, that as the Health Committee will work with you, Dr. Maisha, NASCOP will work with you, NACADA will work with you. PS, you know you always have our support when you come to the committee. Just tell us what you want. And PS, I want to tell you, the route the government has taken on primary health care, it will help us sort most of these problems. This community of worker people are taking as a joke. At the president anajilia watu kusaidia nini? Watatusaidia hii mambo ya HIV, PS, this is something the president will never neglect. Mwambie endelee na hiyo mambo na sisi tunamsupport. You know, I went to Rwanda 2 months ago. I had one guy from Rwanda challenge me. Ilikuwa kitu kama 6 jioni, mpaka nikaenda kulala immediately because I felt like a fool. Hata vile alikuwa ananiambia twende nje nikutreat kidogo, I felt like a fool. Nikaona I can't even have a discussion with this guy because now he is seeing me like a fool. So I told him I have a headache, let me go and sleep. Akaniambia, nikamuuliza, nyinyi watu ya Rwanda, hii mambo ya COVID ni aje mliweza kumanage COVID haraka hivi? Akaniambia, because you people made a mistake. When COVID broke out in Rwanda, all their children in MTCs, all their children in university doing medical and all the courses were turned into an army to fight COVID. Lakini sisi tulifunga KMTC tukwambia ndeni nyumbani, kumekuja COVID mutakufa. Hata Nairobi University, hata wale doctor wako 6th year, wale wana specialize pia tulifunga tukawaambia ndeni nyumbani. Alafu tukaenda nyumbani tukatrain their mothers to help fight COVID. Sasa wewe uko KMTC unafanya clinical medicine that year, umeambiwa beba mizigo, COVID imekuja, enda nyumbani. Ukifika nyumbani unakuta mamako amekuwa trained. So akaniambia, you lost an opportunity, you had a whole army that you did not use. So I felt like a fool. I was with Dr. Jikolo, I felt like a fool. So we need to be more innovative. Now this community of workers thing is one of them. We need to be more innovative. The involvement of communities I've seen here when introductions were being done here. The commercial sex workers, we have them here. Those people living with HIV, we have them here. Those people used to use drugs, we have them here. So it's a very comprehensive meeting. So PS, I want to give our assurance on behalf of the other committee, our commitment in the National Assembly. And we told the people of Epidemics yesterday that we are a very different committee, committed to our work, because I know my committee, not the normal politicians. If we give our commitment, PS, we give our commitment. We'll support you, and this is important for the country. We can't discuss the economy of our country taking health to a back seat. Because our healthy nation, hata hiyo mambo tunasema ya development yote, it will come back to zero. So mimi nataka kumalizia hapo. I came with my colleagues. I have my senior Dr. Nyikal there. That's the encyclopedia of our committee. Wakati tuko kamati, mambo inaleta kisilani kidogo, we talk to Dr. Nyikal. We have Honorable Kibagendi there. When we came to Parliament, we formed a caucus on drug abuse. You know, Kibagendi is always very strict on me. Nikisema saa zingine nikisahau nasema namuitanga chairman wa caucus ya drugs. Ananiambia unajua ukisema hivyo inakaa ni kama ni ya kutumia drugs. So ni against drug abuse. Anaitwa Mheshimiwa Kibagendi. I was with Honorable Olon. Imetoka kidogo for some consultation. Na wabunge wengine ambao tulikuja na wao. But we are here, good people. Throughout this conference, we will take part in every deliberations. We are committed to this, and we have a lot of confidence, PS, in people learning this thing. With those very many remarks, I want to welcome my brother, Governor, rafiki yangu. Sasa wewe Governor, umekuwa Governor ukuwa kijana sana. Tumpigie Governor makofi. Yule, my sister aliongea akasema youth should never be left on the table again. I want to tell you, my sister, I'm with you. Na saizi, unless you young people feel you, youth wako kwa mesa zote. Si ni governor? This man sits in the Council of Governors. Alafu tunasema youth wamebaki. Unless we the young people now let you down. The man talking here is the vice chairman of all in this country. So unless we let you down, and I'm telling you, we won't let this country down. We won't let the young people down. Karibu Governor.
Tupigie makofi huyu rafiki yangu, our chief guest, our PS, rafiki yangu Hari Kimtai, the Minister of Health officials led by the Chair and CEO of Epidemics, and also the NADP, or the Population Control. All stakeholders, all our MPs, led by the Vice Chair, Senator Muma, who has talked very passionately. All stakeholders in this field, good afternoon. First and foremost, I want to take this opportunity to appreciate all of you led by the Ministry of Health, for convening this very important stakeholder forum, this conference. I want to thank you most sincerely, the team from Syndemic Control. And I want to tell you that I'm one of those leaders. As much as I look, I'm young. I've actually done 5 years as a deputy governor in my county. And I'm one person who has been passionate in this front. And immediately I became the governor of Elgeyo-Marakwet County. I was very mad at some of the statistics that used to come. And as a parent, and you know, some people who come from my county, we're almost the same as the Meru people in terms of anger. When I hear that someone has impregnated young children, when I hear that a father has raped his own daughter, and that happened in my county, that thing made me so mad to the level that I declared, because the police were not helping me and the chiefs were not helping me, and I had to announce as the governor, and I was actually in problems with the authorities, but I had to make that decision. And I announced that anyone who is found raping a small child, 2-year, 3-year-old, being the father or not, we are going to lynch you, and the governor will be in that place where they will be lynching you. And from that day, there were changes because some people were beaten, and I was very polite. I was telling people, when you get such people, arrest them and take them to the police. And as you are taking them to the police, you can do some work. If he gets there alive, he's okay. If he doesn't, it is because of the rage that was burning in me when you find some people destroying the future of our children. When you're impregnating a child, you are automatically, if you are HIV positive, you are automatically infecting a minor. And that made me very mad. And I just found myself in this crusade unknowingly. And I've said time and many times that I'm going to fight this war to the bitter end. I know my PS here is a very passionate guy. He was our PS in livestock. He did a lot of work to the grassroots. PS, I want you to lead this campaign and make sure that we help this team to ensure we transform. I will not even read my speech. What I want to say is that I want to congratulate my sister. The senator has given us very good proposals, including my MP here. I think we are in the right hands this time in terms of policy. And I hope you guys can be able to work together to ensure that we transform this thing. I want to appreciate, PS, when I also became governor, I met these guys from Syndemic. And when I met them, I had played to my people that I want to have health as my priority. What we did, when they came with a triple threat, I was very happy. And I know many of my colleagues never understood what these guys were doing, but I took it very fast because I'm a swift guy. And I took these fellows to my county. Immediately we met as all MCAs, all CECs, and the church. And we started doing medical camps in my county. I'm doing my 9th ward out of 20 wards. When we go, we are actually, where is Cheriot? Cheriot from regional, he was my regional director of Syndemic. Cheriot is here, and the lady Faith. Cheriot is there. They did a wonderful job, and Faith, when we were doing that, and what we did was actually benefiting 1,500 to 2,000 people in one ward. People were coming, and the bishop was doing a mass, very quick mass of less than an hour, and after the mass, some lady who was very passionate also with Daktari here, there was a lady who was HIV positive and has come out openly, and Mama Jonjo, and she was talking to women, and it was very lively. When people were living there, they had been tested on several things, ailments, they had been given drugs, they had been preached to, and they had been told about the triple threat. They left a better community. And I want to request today in this conference, we have to change the approach. And I told Syndemic that the amount of money that we use in conferences, the amount of money that we use in small caucuses that we use is quite a lot. Ask me as a governor. When I go to a meeting, I can address a meeting with less than 30,000 shillings in my pocket by buying only a crate of soda, and I give people, and I talk to 1,000 or 1,500 people. It is much cheaper than me going to a meeting, stakeholder meeting, 20 of us, spending 500,000. I would have done 20 forums in my county and created several other people. So I want to request that if possible, we have small planning meetings, and I appreciate you for opening up this meeting. We should not be preaching to ourselves, preaching to the converted. We have to go and preach to those people. There is a success that we made as a country in the years 1990s and 2000s, and I'm told the veterans are here. The success was we went to every primary school, every secondary school, every village preaching about HIV/AIDS. That is how we won, and we win it by head and heart. You don't win it anywhere. You win by changing the mind and changing the heart. Just like what I'm doing in banditry in my county. We have a huge serious issue on banditry and guns. And we have decided, the police have been doing operations all those years, and we have never won. The only time that we are starting to win is when we are now preaching to the people, talking to the people, changing their minds, changing their activities, and eventually we are slowly seeing it works much better than actually doing all these other things. The second thing that I want to see is we need to incite the public against these double threats. If you incite the public against it, like for me, I'm now inciting the public against bandits. Even yesterday, the public themselves returned animals which KDF cannot return. But the public returned because we have started inciting the people. Why don't we start inciting our community against these three threats? And eventually, we are going to make sense. The fifth thing that I want to talk about is commodities. KEMSA, PS, we are not going to do it ourselves. If you can streamline for us, I know you are doing a lot of reforms in KEMSA. If you can continue streamlining with your CS, the challenges that we have in KEMSA, we are also going to help ourselves to transform our places. And finally, we have two ways, and I will suggest to my sister from from Senate, if possible. Financing is a problem. With us being categorized not as a least developing country, we have no choice. Partners will start going. And the best we could do, we have two approaches. In the instant or in the short run, is the Senate to actually craft a conditional grant approach to counties, and we compel counties to start actively supporting all the other stakeholders, so that slowly, as the partners are leaving, counties are being taught that, my friends, you have to start doing this. And another approach is what I heard my MP last week in Parliament saying, that they are doing something on cancer fund or cancer levy or something like that. We should have such an approach even in our place. Or we can even have an approach where we tell all hospitals collecting some small levies, can you have 10% of this go to this fight against this in every hospital down there? Finally, I want to say that PS, I want to appreciate what you are doing, and we hope that we are going to do this well. The only thing that I was suggesting to the Epidemics is that as we have this conference here, can we have some caucuses from sub-county, from county level? We have a caucus or a small conference. After that, we have another team in sub-county, another team in ward, another team in location, and even sub-location, so that this discussion is taken to the lowest possible place. So otherwise, with all those many remarks, I want to appreciate all of us who have been in this war. I want to appreciate all who have been fighting the HIV menace. And I know, even if your reward may not be here, because sometimes we are ungrateful as Africans, your reward will be in heaven because you are fighting for a worthy cause. I want to take this opportunity, it's my singular honor now to invite our PS, Harry Kimtai. He is one of the most efficient PSs I've ever seen in government. And I want to say, PS, with your zeal, we are going to win this war. And by 2030, we should be having better statistics. Karibu sana, and God bless you. Maybe PS, as you start your speech, I want to request you, as we are doing the training on the CHPs, the 100,000 CHPs, if possible, we have a small item on this triple threat as a training in their curriculum. Thank you, and karibu sana.
Thank you so much, Governor Wesley Rotich, the governor of Elgeyo Marakwet. I've known him for a long time, when he was a deputy governor. And when he was telling me that I'm going for the seat of the governor, I looked at him and I said, this young man must be joking. He's too ambitious. But I've realized we need these young men to come and support in our policies, because they now, the people who are talking to our youth, because they are also just that age bracket. I didn't know much about Patrick Munene, that you have also really helped in the health sector and you worked there.
When we met you, and I met you in your county, Tarakanidi, I thought you're from the development side because the way you are driving your agenda issues, it was really interesting. So let me again acknowledge Wesley Rotich for being present here today, the chairman of Syndemic. Thank you for the good work you're doing with your CEO, the CEO of NCBD, and other CEOs that are present here today. Thank you so much, the chair, or representing the chair of the Health Committee, Parliament. I know how passionate you are, how supportive you are to the ministry, and you actually really guided the ministry in most of the areas, and we implemented your suggestions. Thank you, Senator. I've been reading about you so much and the way you are articulating these issues. Today, I've listened to you personally, and I can see how passionate you are. The reforms that we are bringing to both the National Assembly and the Senate, I believe, with the support, is going to get approval. Our development partners, I know you've held us for a long time. Without you, I don't think we will be saying we want to be independent the way you're now talking. You're saying we are ready. We're in the middle level, and we are ready. And you can see suggestions are coming. We want to say thank you so much, led by PEPFAR coordinator, Mr. Brian. I know we've just been talking on virtual meetings when you're coordinating the Global Fund issues, and you've been very vocal on that area, and I know why you're really vocal in that area. I'm told you've really worked in Africa, and thank you, and remain in Africa. That's what you are prayer, that's why that you continue with us. The community leaders and religious leaders who are present today, I think you have been told the role you're playing. Mheshimiwa just said that there's certain areas that even we, government, cannot go when you do not use you. Therefore, you play a key role in development and supporting the government. Thank you so much, community leaders and religious leaders. Ladies and gentlemen, allow me just then to read my speech that I wanted to share with you. I know time has gone, but I appreciate all of you. Indeed, it is a warm welcome to be part of this team that has assembled here today, and specifically on this conference that is dubbed the 7th Maisha Conference. I am honored to be among you today, celebrating the progress made in HIV response, fostering the exchange of knowledge, and embracing the collaborative spirit that defines this conference. Indeed, it is coming out very clearly. This gathering is also a celebration of an incredible partnership that includes individuals who have dedicated their lives to this noble cause. Speakers who have spoken ahead of me have pointed out some of these people who have dedicated their life. Indeed, we also appreciate you. We have witnessed the resolute commitment of scientists, the communities, and all other stakeholders who have contributed to the remarkable progress, which is a testament to our nation's unyielding fight against HIV. In many areas, we are winning. And I think statistics is showing that we are winning. Thank you for your support. I want to give you some history. Between 2013 and 2022, the number of individuals receiving lifelong antiretroviral treatment has doubled. It has doubled. Because now, many people are aware of their status, and we have told them that it should not be a life sentence for you. If you come out clearly and state know your status and go to the healthcare, you will be given drugs. We want to appreciate the scientists who also went ahead and started this innovation and bringing in the antiretroviral drugs that can be used to treat our people. Now, from the figure of 656,000, it has gone up to 1.2 million. I think these are significant progress that we are doing, and we are talking about enhancing the quality of life and curbing the mortality rates, because we have to make sure that we reduce the mortalities. And we take pride in the wide-scale availability of more patient-friendly medicines, such as Geographic, which have yielded support and superior treatment to outcomes enhanced by about 89%. This has suppressed the HIV spread. the individuals who are receiving this retroviral treatment in 2022 are actually, as somebody said, you can't know, because they are living healthy, they are enjoying life like any other person. And our proactive stance in rapidly embracing scientific advancement resonates across various domains. Kenya ranked as the second African nation to adopt a successful implementation of the pre-exposure prophylaxis program for HIV prevention, achieving a noteworthy 64% uptake among all the eligible individuals by the close of 2022. We have effectively reduced annual new HIV infections by 78%. I think this has been shown there by the CEO of Epidemics, and this has reduced from 500,000 cases in 2012 to approximately 22,154 cases in 2022. The AIDS-related fatalities have witnessed a substantial decline by 68%. And this, therefore, we now have a number of about 58,446 that we had earlier. It has come down to 18,473 to be specific. So through gradual increments, we have boosted the domestic funding for the pool HIV by about 33%. And we are yet to increase this to up to 50%. That is our target. Our contributions extends to numerous scientific research endeavors that have catalyzed the breakthrough in the management of HIV. Ladies and gentlemen, this remarkable progress stands as a testimony to the collective efforts of those present and those who have contributed in the past. It is our duty to persist and pursue, and our pursuit of innovations, interventions to eliminate HIV as a public health threat in Kenya. While celebrating our accomplishments, we must confront the enduring challenges that loom ahead. One particular concern is a sluggish pace in curtailing the new HIV infections among children and adolescents. I think that is our next war front, that as we get out of this conference, the message will be out there that we have got to fight this HIV. And I like the demonstration that was there. We have the tap that is pouring into a pot, and again we have a tap that is emptying that pot. We must come up with a strategy that we close the first tap that is pouring there, so that we are able to make sure that we contain these fatalities that we are seeing. And our target, as Mheshimiwa said, are the youth. And the youth is the future of this country. So if these new infections is with the youth, therefore, our gains is going to be zero if we don't handle it. And I think we have learned a lot from our brother from Zimbabwe and what they're doing. And I think as a country, we're also going to adopt some of these best practices that they are implementing in their country. And thank you for coming, my brother from Zimbabwe. So Kenya bears the 7th highest burden of HIV globally, with an estimated population of 1.4 million people that are living with HIV. By the end of, that was the figure of 2022. We do not know now. I think the next statistics that will be done in the near future will show us whether we are increasing or we are decreasing. But if we go by the statistics of the youth who are not, sensitized on HIV, then our number is going to go up. So again, you will see the cost into the treatment of this, because it will definitely then mean that we are going to invest more on antiretroviral drugs. That means we are going to drain our economy if we do not control this infection. I also want to say that while the HIV or AIDS-related deaths are on downtrend trajectory, the loss of lives remain unacceptable. The declining in HIV-specific funding from external sources is a trend that is being observed. And again, we have been given a warning. The development partners have partnered with us, but they have told us that by 2030, in fact, it was by 2027, they will be packing and they will be going away. We requested them to stay until 2030. Now, 2030, you might think it's very far. That is only 7 years down the line. Are we ready as a nation? I'm happy that the governor is going to engage with the Senate and the members of parliament so that we're able to come up with the funding programs or how we're going to resource to develop, to make sure that we have resources to fund our HIV/AIDS programs. So ladies and gentlemen, as we convene here today, it is evident that maintaining and accelerating progress requires our collective commitment. The diversity of the delegates here that are present in this forum is both encouraging and inspiring. I know my brother there. Is it Hamed? Yeah. This young man, we are together in the KCM, the Kenya Coordination Mechanism, and he's very vocal, and I like him because he brings out the youth in it. And therefore, we are saying they are part of us, and therefore we must plan with them. We cannot leave them behind. Thank you, Hamed. And I know you still have my photograph, so you'll bring it back to me. He knows why the photograph is there, because the first time we met, he took a photograph, and he said, I'll keep it for you. And I've always requested him to bring me back the photograph. But he says, I'll keep it until we conquer this HIV. So I want to really thank all of you for your commitment in fighting HIV, because out of here, we are all going to be ambassadors of HIV. And on this note, I extend my heartfelt congratulations to the distinguished awardees that we are going to give today. I've been given their story, very inspiring story of how they have persisted, how they have helped this nation focus on fighting HIV. And today, the 7th conference, we are going to award you, and specifically Mr. Nelson Otoma, who is present here with us today, Dorothy Onyango, and our academia, they have not let us down, Professor Ruth Ndwati. Your exceptional contributions have been transformative, inspiring, and shaping the landscape of HIV response, and have undeniably saved countless lives. Countless lives. You can imagine you're reducing from 101 to 58, and the figure is going down. These are the people that we need in the country. These are our heroes. And I want to assure you that as we are going to celebrate our Mashujaa Day, I think with the recommendations of this Maisha conference, please allow me to submit their names to be as our heroes in the health sector. I know they have advertised, but I want the National Syndemic Council to bring their CVs and to give us how they have fought this disease, so that the nation is able to celebrate them. Let's not just celebrate them here. Let the nation know that we have our heroes, we have our Mashujaa in the health sector. Thank you so much. So your achievement stands as a testament to our collective triumphs, reminding us of our past successes and our reinforcing the potential of our future, where victory over AIDS is going to be realized. To all delegates, I wish you a deliberation filled with fruitful insights and meaningful discussions. Your presence here signifies the dedication and commitment that propel our mission forward. I would like to express my gratitude to the community representatives present here today, our bilateral and multilateral partners for their fruitful and consistent collaboration in HIV response. I'm told most of the technical team from the counties have been supported by PEPFAR. I want to thank Brian for supporting our technical team to be part of this discussion. We hope that will continue in the future. The governor said we now need to go out. We need to go to these conferences, to go to Mashinani, down to the villages, so that it is cascaded down to the villages. We hope our development partners are going to take that response. So let us together continue charting our course towards a brighter and healthier nation. I know some of the suggestions that have been given here, like, for example, Mheshimiwa talking about how then do we increase financing. Senators talked about how to increase financing. I'm happy to inform you that indeed the ministry is working out on reforms within its legislation so that we're able to factor in the funding component. One of those legislations that we have worked very closely with the governors is the Facility Improvement Fund. The Facility Improvement Fund is going to make sure that all the funds that our revenues that are collected from the health centers, from the hospitals, remain within the hospitals. They are not diverted to go to other areas. So we are very happy that 27 of those counties have already embraced that, but we are submitting now a bill through the Committee of Health that we want the entire 47 counties to adopt it as one. And therefore, those are some of the reforms that the ministry is working to ensure that we bring in funding within the health sector. The ministry is also looking at developing other legislations, looking at the successes in other countries like Zimbabwe on how they developed their trust fund, the HIV trust fund, to make sure that we now have a fund that is going to take care of our AIDS programs. On the issue of reforms in KEMSA, I want to assure you, Excellency Governor, that indeed we have reformed KEMSA starting from the top, because our biggest challenge in KEMSA was the governance on how they were running the institutions. So with this, just few changes in terms of governance, the fill rate of KEMSA has moved from 53% to over 60%. And we are targeting to arrive or to achieve a 90% fill rate, because there is no need for sure for our patients to miss drugs, and especially the HIV drugs. There is no need really for that mother to miss the HIV drugs. And I'm very passionate about it. We've discussed with the governors. We are going to make sure that the fill rate reaches 90%. I know there are cases where it is simply just a question of distribution, where it has not been taken to the last mile. Surely, as a nation, should that be a problem? And I'm happy that some of these counties have adopted the new technology, the use of drones, for example. Kisumu now is adopting drones. Nyamira is adopting that. So why should we then use very expensive method of transportation, yet we need a specific quantity to be in certain facility? A whole rolly taking just few cartons. Why not use this new technology, the drones, for example, and deliver it within time? So Nyamira, thank you for taking the lead, and Kisumu also, and I think it is because of Professor Nyikal. You have been in this sector for so long, and Kisumu is not being left behind. Thank you so much. So those are some of the areas that we are focusing on. We want to bring reforms within the sector. Now, the community health promoters. I want to inform you that the community health promoters is now going to be a reality. His Excellency is leading, and I want to inform you that we have already procured the community health promoters kits. And what the community health promoters are going to do is engage the community. They are going to be the first level of reference for health-related issues. What we are providing in the kit, number one, is we are giving them the glucometer to measure their issues of sugar. We are giving the blood pressure machine just to know your status in terms of when you wake up, when a family wakes up in the morning and you take your pressure, it gives you your status, where are you? The other one is we're giving them simple support in terms of, we are giving them chlorine, for example, the tablet, something that we normally forget, that if you drink your water that is safe, water that is clean, then you have already prevented diseases. So we are giving them additional other information like the weighing scale, just to take this weight of the child to know whether this child is malnourished or not. So these are some of the areas that we want these community health promoters to start engaging the members of the community in terms of their health, just to awaken them in terms of what you need to do. Now, as we continue with the training, a very good component that has been suggested from here, and I think I'm going to tell my team that we need to incorporate the 3 threats that we are talking about. And if this is communicated to our community, I believe all of us will be aware about it. I want to assure you that that is the message that I'm taking from here, that indeed we need to change also our conversation, our dialogue, to include what policy has already arrived at. So ladies and gentlemen, I do not have much to add. I just want to give you our commitment of the Ministry of Health in supporting the stakeholders, in bringing everybody on board so that we fight these diseases together. Thank you and God bless you.
Thank you, Bwana PS. I kindly request you remain on the stage for a few minutes so that we can acknowledge and award our heroines and heroes. So first and foremost, we have 2 categories. One is individual categories and another one is the groups categories. I will manage the individual categories, whereby we are having our first person in recognition of demonstrating extraordinary leadership in advancing sexual and reproductive health rights and economic empowerment among people living with HIV. Ladies and gentlemen, rounds of applause for Dorothy Onyango. I want to invite the chair and the CEO and SSDD and the governor. Please, karibuni sana. We present this award. Karibuni sana. Karibuni. Wapi makofi ya Dorothy? Dorothy is the CEO of Workers Women Fighting AIDS in Kenya, and she's also an author, and this is a book. Kindly feel free to go through it, and you'll learn more. Makofi tena ya Dorothy, please. Let's have a photo. Kindly, let's have that photo. Thank you.
Now she's telling me she got the OGW, but I think that is not the end for her. We need her to go up so that she gets the Elder of the Burning Spear. All right? Yeah. Thank you. So in recognition, we're also giving you a certificate just to thank you. I know these certificates mean nothing, but if you show to your children and you show to your community that you have been given a certificate, it means a lot. Thank you.
Thank you. Rounds of applause to Dorothy. Kindly, Dorothy, come on this other side so that I can welcome the rest. We will have a group photo later. And now, next on stage, ladies, in recognition of demonstrating exceptional courage and transformative leadership in confronting HIV-related stigma and discrimination, is none other than Nelson Otuoma. Makofi ya Otuoma, makofi yake tafadhali. Wapi makofi ya Maisha Conference? Karibu so much, Mr. Nelson Otuoma. As you receive, please. Makofi tafadhali. Thank you. Thank you, sir. Come on this other side kindly. Thank you so much. Last but not least, on the individual category, ladies and gentlemen, in recognition of demonstrating experts and significant scientific contribution towards HIV prevention, treatment, and care for children in Kenya is none other than Professor Ruth Wanjiku Nduoti. Wapi makofi? Wapi makofi jamani? Karibu sana Professor. Karibu sana. Thank you so much. Thank you. Karibu. Karibu sana.
academia, we have people that we can trust in fighting HIV. Thank you so much.
Thank you. Makofi tafadhali. Thank you. Thank you.
Here. And I think Duarte needs to come in here also to just for the support. You know, they say every successful woman, there is what? There is a man behind. There's a man behind these successes. Thank you so much. Thank you.
38 years of HIV.
38 years. He's the one confirming. Nobody else can confirm that. It is only Engineer Duarte who can confirm that she's been there 38 years. So you can imagine. Let's give another round of applause to Duarte.
Thank you.
Yeah, and what is that? I just wanted to give him just a minute of your time.
Thank you very much. I just want to add one point. I'm probably the oldest person here. I'm 70. And two things, we have ignored the older generation. They are aware of wisdom. There is no country which can grow when you ignore one sector. There is something you can gain from the gukas, the shoshos like me, and get it imparted to the youth. There is something too we can get from the youth. If we remember, our freedom for this country was fought for by the youth. So there has to be synergy between the youth and the older people. But, so, let me finish. I heard the young people say they are blaming the older generation. We have made our mistakes, I agree. But we shall leave you here for 20 or 30 years. So you have to have time, you take responsibility also. Don't blame the older generation for everything. You can also take some responsibility. I can say much more if given the opportunity, but thank you very much, PS, for that opportunity.
Thank you. We acknowledge you, Engineer Duarte. Something very important. I think we need a conversation. We need a society. We don't need individuals. We need a society approach to these issues. Once we take that, we have included the youth, we have included the adolescents, we have included the elder generation. We need the society. Thank you.
Thank you. Thank you so much. And before we introduce the next category, kindly, it will be just fair to make sure that we have our heroes and heroines here to say a word, and then I return the microphone to the chair before we welcome the two counties that have also done marvelous. Without further ado, let me start with Dorothy. Just a word, and then you pass the microphone to the next.
Thank you very much. I want to take this opportunity to thank the National Epidemics for thinking about my efforts, the fight with HIV for 33 years now. I'm glad that I'm still here because of the ARVs that we have received from our development partners, and it has been made our life, we live longer. I'm now aging with HIV, and this award is not for me only, it's for the women that we have struggled with who are here. Thank you very much. As we were counseling you, I was counseling myself. That was my hiding point. So it is for all of us. Asanteni sana, and we look forward to continue working for communities of people living with HIV as a network of people living with HIV and the network of, and the National Empowerment Network of people living with HIV that covers all of us. Thank you very much, National Epidemics, and thank you, the peers, and thank you, Brian, for the support that you have seen the ARVs have done to us. You can see it. So, asante sana.
Thank you so much. Professor, kindly. Professor, kindly.
Thank you very much. I feel very honored by this award. I met HIV as, I'm of the generation of medical doctors who was trained by the Kenya government. I did not pay school fees for university, other than a very little loan towards the end. I then got the opportunity to work in rural Kenya, come back for my postgraduate training, got excellent education, such that when HIV arrived and we met, we had some little capacity to start responding. I want to say that as I received this award, we need to go back and rebuild the pipeline for training highly qualified health professionals. It needs people who are trained many years to be able to meet the problems that our nation expects. The current policy that a medical officer intern is let go to go and look for a job, and that maybe they might come back for postgraduate medicine, is killing the health services completely. It takes many years of many years of seeing many patients for a physician to become successful. I want the physicians, the people who are our age groups, consultant physicians, consultant pediatricians, senior lab people who might be here today stand up, and they will confirm to you it is many years of practice, having been supported by the government of the land. So I could talk on this for a long time, but if nothing else, Sylvia Joe, physician, led NASCOP for a period of time. If nothing else from this meeting, let us go and relook at the pipeline of how to support people to be highly qualified. God has blessed Engineer Duarte and I, and we are parents of young consultant physicians. My firstborn son is a neurosurgeon. It's taken many years. We have paid school fees for him for many years for him to reach that state. His brother is a radiologist working in Cabinet, the same thing. Today, the child of a poor person coming to medical school will be destroyed by the process, and his family too will be destroyed by that process. That is not the promise of what we ask for.
Thank you.
So we must correct that. So, but thank you for this. I know my grandchildren will be very pleased.
Thank you, Professor. Rounds of applause to Professor. Thank you so much. Last but not least, Mr. Nelson Otoma, please.
Thank you very much. I think mine will be brief and start by thanking the Ministry of Health and the NSDCC for this recognition and award. I really feel honored. Thank you very much. I already spoke for those who are not here, and I said Kenya, I think we are in the path to end AIDS as a public health threat, and I wanted to thank the Ministry of Health because they are putting us in that path. And I also said that the Ministry of Health, right now we are discussing through the leadership of the PS how NHIF can take up HIV treatment, and I want to put a request that we are happy for partners, Global Fund, PEFA, and Brian is here, to support other components, but today I want to call upon the Kenyan government to take ARVs because it is lifelong treatment, and we don't want the anxiety of saying maybe there is a stock out or maybe something is unexpected. And we are sure that it will be guaranteed to us if NHIF and the government of Kenya invest in it. So we appreciate your effort and your leadership. I want to make an announcement. This afternoon I'm chairing a session on people aging with HIV, so that we see the link between HIV and non-communicable diseases and how NHIF can come in. And I also want to say that we welcome all of us to World AIDS Day, and World AIDS Day December 1st, simply because the theme is Let Communities Lead. Thank you very much.
Thank you so much. And now I want to hand over the microphone to my senior to also appreciate and award the 2 counties that make a massive success. Karibu.
Thank you very much. Now our heroes and heroines, you can take a seat as the rest remain on the podium. I would like to request Dr. Timothy Ombati, the Secretary General of the caucus of CCMs, to come to the front, please. Senior, Dr. Gishuya, I can see you here. Kindly come. We are going to reward counties this time around now. PS, our target towards eliminating mother-to-child transmission of HIV will only be attained if we attain a national figure of less than 5% transmission rates per year. And for the first time, we are happy to report that our 2023 HIV estimates are showing us that Siaya County has broken that magic line of 5%. And Siaya County became the first county in Kenya to record 4.3% mother-to-child transmission of HIV. Makofi kwa Siaya County. To receive the recognition on behalf of Siaya County is the County Director of Health, Ken Orenjo. Where are you, Ken? Karibu tafadhali. Akuje na makofi kabisa na vigelegele. Thank you. And you are joined on the podium also by the leaders of the CCM caucus. They're here. Governor Wesley is there, so that you can award them together. Please. Yeah. Karibu. Yeah, please. Yeah. Makofi ya county ya Siaya. Na Governor James Agri Orengo. Thank you very much. Thank you. Next, a county that has also excelled in elimination of mother-to-child transmission is Migori County. Migori County has recorded 5%. They are on, hapo kwa age. Wanataka kutoboa hiyo kitu kabisa. So Migori County is represented by Dr. Julius Nyerere, who is the County Executive Committee member for Health Services. Daktari, karibu. Thank you very much. Maybe the photo can be taken now. Asante. As the rest of us remain seated, there is the last bit. Remember, we were talking about ending the triple threat and also the journey towards ending HIV and AIDS as a public health threat by 2030. So we are going to launch two documents. Nowadays, we launch documents digitally. They are available. The first document will be the multi-sectoral prevention plan towards ending HIV. And PS, what we'll do, we will all come this side. There's a buzzer here you'll press. And out of that, we'll see how the document looks like. Makofi ya PS anapokuja. Thank you. So the rest of us can flank the PS. Are we ready? Jay, are we ready? All right. Yes. Do the countdown, Pato.
Yeah, thank you. Ladies and gentlemen, we'll be having a countdown as we celebrate this launch. And immediately after this, kindly, let's break into jubilation and celebration, okay? Are we ready? Digital team, kindly. Let's go. Let's start. The countdown. Now, 5, 4, 3, 2, 1. Let's go! Finya kabisa. Yes. Let's appreciate kindly. Let's appreciate.
That is the multi-sectoral HIV prevention plan that has been officially launched by our PS, Harry Kimtai, and his team of delegates. Pleasure. There's one more. Our roadmap towards ending the triple threat. Right? The next. Jay?
Next one, please.
That is the roadmap that Dr. Sheikh was talking about, the roadmap towards achieving a multi-sectoral effort on ending the triple threat in the country.
Let's go. Let's celebrate. Makofi. Thank you.
Thank you, thank you, thank you, thank you.
Thank you. Basi, we'll request the chair, Mr. Geoffrey Gitu, for our word, kindly. Mr. Chair, karibu sana.
As the chair comes to give the vote of thanks, because of time, as we break for lunch, there are 6 sessions set for this afternoon. The session that was supposed to be in Shimba as from 3, the management of the layered complex situation on ending HIV by 2030 will be held in this room. The rest of the sessions will be held for 1.5 hours strictly, and at 4:30, the second sessions will begin. So the first sessions will begin as they are on our program, but it will also include that session that was to be held in Shimba breakout room as from 3 p.m. They will meet in this room that we are doing the plenary. And the 2 other sessions will begin at exactly 4:30. Thank you very much, and welcome our chair, NSDCC, Geoffrey Gitu.
Thank you very much. Good afternoon. Our chief guests, PS Harry Kimtai, Your Excellency Governor Wesley Rotich, the chair of Parliamentary Health Committee, Patrick Monene, members of Parliament, our senator, and our development partners. I just want to thank you all for gracing this occasion today. But PS, allow me to let my board stand so that they can wave to people. I will start with, I think, Dr. Sankare, Dr. Ojo, Professor Ojo, Andrew Rokaria, our old man, Marco Buya, Lucy Gatti, and the representative from Treasury, Director Patrick Masharia. We want to thank you all, and we want to say we didn't recognize every one of you. We know we have other heroes, and we will do that at the Maisha, not Maisha conference, at the World AIDS Day. I want to thank you, our chief guests, and all our guests, and asante sana for the support that you've given our institution, and we look forward. We still owe you a visit, or you owe us a visit, as you had promised. So we are still waiting for you. Before I go, I just wanted to say, I confess, my name is Geoffrey Gitu. I'm not as brave as my CEO. I'm a grandfather. And being a grandfather is evidence that my children have engaged in sex. But I did not. I want to confess, I was not part and parcel of that sex education. And I'm sure even my directors have not done anything to that effect. But all in all, I think now we have learned today that we should have sex education as a way forward. Okay, have a good day and enjoy your lunch. I think I'll call somebody to pray for lunch before I go. Director Lucy, come and pray for food.
Main restaurant.
Huh?
Yeah, lunch is served.
Oh, okay.
Lunch is served at the main. They'll be issued cards at the enter.
Sorry, I had not